I request Dr. Vijay Arora to felicitate the speakers and chairpersons. Now we'll proceed to our inauguration and lamp lighting. I request all the EDPA executive members, president, vice president, treasurer, and chairman scientific committee, and also the past presidents and organizing chairman Dr. Makkad, organizing co-chair Dr. Harshita Tyagi to kindly proceed towards the dais. We'll be having the inauguration ceremony. I also request the Dr. Paras Gangwal to deliver the welcome address.
Thank you, Swati. And with this inauguration, I formally declare this conference open, which is EDPA's endeavor for a physician awareness campaign towards antibiotic stewardship via pathway of a diagnostic stewardship. That it's an awareness campaign for the physicians to realize the role of their healthy microbiota. So keep their patients healthy. We need to design our precision therapy in such a way that we kill the microbes, but we do not overkill. We need to differentiate between the good bugs and the bad bugs. So I'm happy to welcome you all. I am also happy to announce two great honors being initiated from this conference. One is Best Teacher Honor, and another is Shri Om Prakash Khari Oration. I request all the EDPA past presidents to honor Shri Dr. G.D. Gupta sir with the Best Teacher Honor along with inauguration and lamp lighting. While we honor Professor Dr. G.D. Gupta, who is teacher of teachers, let me invite Dr. Anil Chaturvedi, who is one of his senior most students amongst the many students of Dr. G.D. present here, to say a few words about Dr. G.D. Gupta, sir.
Guru Brahma, Guru Vishnu, Guru Maheshwara, Guru Sakshat Brahma Tasme, Shri Guruve Namah. It is a historical and memorable moment in the history of EDPA that we have decided to honor our excellent or the great teacher, Professor G.D. Gupta. An ordinary teacher tells, a good teacher explains, a superior teacher demonstrates, and a great teacher like Dr. G.D. Gupta inspires the confidence. Today, he has inspired till now the 3 generations of students in his 70 years of career of medical profession. I have, with all his academic flavor and fervor and scientific bent of mind. With a successful man, there is always a woman, and EDPA is also privileged to have Mrs. Gupta, who is a embodiment of simplicity, honesty, humility, and dignity. Madam, I can only say about Mrs. Gupta, Nari tum keval shraddha ho, Vishwas rajat nak patal mein, Piyush shosi baha karo, Jeevan ke sundar samtal mein. We are honoring Professor G.D. Gupta, our esteemed teacher, for more than 60 years.
See, in addition to being a very great teacher, which we all had the honor of studying with him, a great sense of humor also. See, about about murmurs, he would say, murmur does this, but he had a great sense of humor, which was very inspiring thing in him.
So while the honor to Dr. G.D. Gupta is ongoing, I'll request the Master of Ceremony, Dr. Swati, to continue with the session. And the next session, of course, is the oration ceremony, so we can start. Kya jeet, sir?
Thank you, sir. Now, I request the executives, president, both our vice presidents, treasurer, organizing chairman, organizing co-chair, and chairman scientific committee to join us on the stage. I request all the executives to kindly join me on the stage. Dr. Anirudh, Dr. Ashok, Dr. Viresh, Dr. Rajiv Bansal. Sir, all of you are requested to kindly join us on the stage. And the oration has been conferred to Dr. Rajesh Chawla. I request Dr. Lalit, Dr. Paras and Dr. RPS Makkar to escort Dr. Rajiv Chawla to the stage. I request Dr. Lalit to say a few words about Shri Om Prakash Khari.
Good afternoon and my colleagues. Well, today I'm honored and grateful to be able to dedicate an oration in the name of my father, Mr. Om Prakash Khari. Well, the idea behind this oration was not only to pay homage to my father, but also about the influence that parents or mentors have on a person's life. Through their actions, they influence a person's values and ideals and mold their way of living, their choices, their contribution to society. I would like to share some anecdote about my father, about his life journey and how he left an indelible mark on me and my family's life, amongst others. My father, Mr. Om Prakash Khari, was born in a small village called Sisoli in Meerut in 1915. He was the eldest son of 5 siblings. His own father was a farmer who had the forethought of educating his children, as he did not want them to endure the daily toils of farming. As a young man, he studied and went on to acquire a job as an accountant in the government sector at the Central Defense Accounts in Meerut. He was the first one in the family to transition from a blue-collar to a white-collar job. During his college days, he also took part in freedom struggle along with his cousin brother, Mr. Kashinath Khari, who was a freedom fighter. He eventually settled down in Meerut, got married, and began his own family, which included 6 children, 3 sons and 3 daughters. Influenced by his father's thinking, he decided to strive for a better education and opportunities for his children, which he could not envision happening in Meerut at that time. So he decided to shift his family from Meerut to Delhi. The problem was that he was unable to get his government job transferred to Delhi. So despite the dilemma of having a job in Meerut, he went forward with that endeavor. To make it work, he used to leave at 8 a.m. in the morning, 4 a.m. in the morning every day, as there was no other available transport at that time. He would walk 12 kilometers from his residence to Old Delhi railway station, then travel standing on most days in the park, rushed train to reach his office in Meerut at 9 a.m. After he got done with his work, he used to take same route back and usually reach home at 11 p.m. when most of the family was asleep. He used to make this arduous journey for almost 2 years. We used to see him once only on Sundays. Despite being run-rugged himself, he was not annoyed or never came back home in a bad mood. Budgeting for a family of 8 members was a relative menial salary of a government job, as one can imagine, was an uphill task, being the sole earner without any other alternative source of income. But still, he did the best he could do. Even when times were tough, he always strived to see the best in people and in life. An active person in his twilight, after retirement from his government job, he worked in a private sector for 22 years, just to complete all the responsibilities like the marriage of his children till the age of 82 years. He was honest, humble, encouraging. He never believed in losing hope, even if we failed. Stress was not a word in his dictionary, and he always emphasized the value of education above all. As you can imagine, walking 15 kilometers every day for 2 decades, he was the fitter 80-year-old you would like to see. He took no medicine for any illness, never got admitted, never got operated even for cataract. He did not smoke or even have any such vices. But as life would have it, as a surprise to us all, he suffered a stroke in 2006. Even after suffering from such a debilitating condition, he always tried to keep a positive outlook on things and never prescribed to being a cynic. He finally left us for heavenly abode in 2007 at the age of 92 years. Today, his 3 children are Dr. Rajiv Lochan and myself are founding member of EDPA and also the past president. Can I have a chair here, please? May I request my elder brother, Dr. Rajiv Lochan, who is eldest in the family, to please come and let you see other people. Because आगे ऊपर लाओ. This oration will be incomplete if I don't talk about Dr. Rajiv Lochan, the crucial role he has played during our childhood. Since my father used to be away from home for office, Dr. Rajiv Lochan single-handedly took the responsibility of family education, motivation, and doing most of the fatherly work. He was the first one to get admission in MBBS, and everyone was so motivated and wanted to follow his footsteps. Today, I am standing in front of you as a doctor only because of his dreams and my belief in him. I'm not wrong if I call him a father figure due to us, is a father figure to us due to his great contribution in our childhood. Thank you, Dr. Rajiv Lochan, brother, sir, if I rightly call you. The third children who is a doctor is also my sister sitting behind, Dr. Sarla Sharma and Dr. Rajesh Sharma, who have a nursing home in South Delhi. May I ask them to stand for a while? They have a nursing home in South Delhi. Everybody knows them. They are very active in South Delhi branch. One is a principal, one is a businessman, Yogendra Khari, who is also sitting here. Ask him to stand. No doubt it is his spirit that has driven each of us forward to whatever we are in our life and will continue to guide us in the future. From his family tree today, we are total 15 doctors in many different specialties. 2 young doctors, Dr. Anubhav and Dr. Anirudh, who are now EDPA members. I think Dr. Anirudh, everybody knows him. He is the most dynamic vice president I have ever seen in my life. And Anubhav is my son, who has done MD medicine, sitting behind. Can you ask him to stand for a while? He's also EDPA member. Latest entrance is Dr. Kriti, my daughter, who has passed MD dermatology last month.
We'll request Anubhav to join us on dais.
May I request Kriti to please stand? Dr. Kriti to stand on her place. Nobody can see you. Achha, she's there. She's standing here. Difficult to see you because you just behind you is a light. Other doctors who are present here is Akanksha, Urvi, and with their husbands. They are also sitting behind. Can you wave your hands? Thank you. My father's great dedication and belief.
I think all the generation come here close to the dais for a quick photograph. Just be dynamic.
Afterwards. His great dedication and belief in the importance of being resilient, working hard, and his vision of providing his children the best environment possible, sometimes to the detriment of himself, made it possible for the children to pursue their dreams of higher education. It has consequently, in the end, led to great contribution overall to the medical fraternity. For his everlasting influence on my life, I still give me a source of love, strength, and guidance even today. I have dedicated this oration in memory of our loving Father. And to all you gathered here today, I'll urge you to celebrate and cherish your own parents, your parental figures and mentors, and to empower the generation with us. Well, in the end, along with my wife, Dr. Shraddha Sharma, I thank the President of EDPA, Dr. Paras Gangwal, who has accepted my request for an oration, and the oration committee comprised of Dr. Prakash Gera, Dr. Rajiv Gupta, Dr. Vijay Arora, Dr. Rajiv Bansal, for granting it for 5 years. Dr. Ashok Guru also sitting here. And all my relatives who are gathered here, my brotherly neighbors, Mr. Neeraj Aggarwal, Mr. Manmohan Aggarwal, and in the end, the most important being my eldest brother in the family, Mr. Ravinder Khari. May I ask the eldest brother in our family? Thank you. And in the end, I must thank the speaker of today's oration who has taken the request, accepted the request of delivering oration in the name of Father, Mr. Om Prakash Khari. Thank you very much.
Now I request our President, Dr. Paras, to say a few lines about the guest speaker for our oration.
Thank you, Dr. Lalit. So inspiring, and through this oration, we all thank our parents here for bringing all the good qualities of life in all of us. Thank you, Dr. Lalit, for this wonderful oration. So now it's my honor to introduce none other than Dr. Rajesh Chawla, who will be the first orator for this oration. We know Dr. Rajesh Chawla very well. He is very eminent chest physician, intensive care specialist, known in all the circles of medical fraternity. He is MD, FCCM, FICCM, FCCP. He is holding European diploma in intensive care and adult respiratory medicine. He has been academic coordinator at Department of Respiratory, Critical Care and Sleep Medicine at Indraprasth Apollo Hospital. He has held multiple positions in Indian Society of Critical Care Medicine. He has been founder editor of ICC, that is Intensive Care Communication, the official monthly bulletin of ISC CCM for 5 years. He is also the chief coordinator of 4C Comprehensive Critical Care course and Critical Care Infectious Disease course. He is chief coordinator of online course for NCCP. He has many publications to his credit. He has been editor of ICU protocols of non-invasive mechanical ventilation, tuberculosis, a practitioner's guide. He has published many papers and contributed chapters into the books. I welcome Dr. Rajesh Chawla to deliver his oration on
Sorry for the interruption. I request all the executives and Dr. Lalit and Dr. Rajiv Lochan to kindly honor our guest speaker, Dr. Rajesh Chawla, before we begin with the oration. I also request all the executives to honor Dr. Lalit with a bouquet. Now I request Dr. Rajiv Chawla to start with the oration lecture. Oh, sorry, Rajesh Chawla, I'm sorry, sir.
Thank you very much and good afternoon. Before the lunch, so I'm going to give you some food for thought. So, chairpersons, the executive of the East Delhi Physician Forum, Dr. Gera was reminding me that I'm part of the founder member of the East Delhi Physician Forum. And I just feel like family when I come to this physician gathering in East Delhi. You know, the topic which I'm going to talk, I think every person who is sitting in the hall is facing problem in managing infection every day. That is the rising antimicrobial resistance and difficulty in choosing antibiotics in these patients. So I'm going to talk about the problem, challenges and diagnosis, how to treat these, and how we can prevent. There are three kinds of bacteria. We all know it. The gram-positive, which are a little problematic, MRSA, Visa, or vancomycin resistant enterococcus, but they are not much of a problem. We have drugs, and we are able to manage these. The two below which you see, one is the funga, Candida auris. You know, Candida cruzi used to be a problem. Now Candida auris is growing in the blood, and the moment you grow Candida auris, 50% patient die, 50% mortality. Purely a nosocomial infection, purely in poor infection control in your hospital, because by the providers it spreads from one patient to another. But what I'm going to stress today is gram-negative bacteria, which are really creating trouble. The Enterobacteriaceae, we know E. coli, Klebsiella, Citrobacter, and non-Enterobacteriaceae, Pseudomonas, Acinetobacter, and Stenotrophomonas maltophilia. These are the three important organisms. And we have the drugs for many years, beta-lactams, penicillins, cephalosporins, monobactams, aztreonam, which is part of this, carbapenem, and beta-lactam inhibitor. The problem is these gram-negative bacteria are now becoming resistant to these beta-lactams. And how do they develop resistance? The bacteria doesn't allow the drug to penetrate. That's number one mechanism of resistance. If it is penetrated, it is thrown out, efflux, the drug is thrown out. The third mechanism is that the target where the drug acts, it is modified. The drug is not able to act. But the most important out of all this is the production of an enzyme, which is called the beta-lactamase, which destroys these antibiotics, because it attaches to the phosphate and destroys the antibiotic. It inactivates the antibiotic. It is no longer effective. And these beta-lactams, which destroy or inactivate the antibiotics, they have been classified into 4 groups, which is Ambler classification. Ambler class A is the simple beta-lactamases. ESBLs. ESBLs is if you find a report resistant E. coli to ceftriaxone, that's a ESBL. You don't require any test to know that it is ESBL. Then the red one which you see, these are the beta-lactamase which have resulted the resistance to carbapenem. And the word used for these beta-lactam is carbapenemase. So in group A, the most important is the KPC, which is not seen in India. In the group B is the NDM, which is creating trouble. And group D is OXA48 enzyme, which is, these three are the most important enzyme which we are seeing and are making our antibiotics ineffective. So when you use the terms, you should be very careful. When I say PDR means it is resistant to all, pan-drug resistance. But when I say MDR, that means in my report, the 3 classes, 1 drug is at least resistant, that's MDR. And XDR is, it is all resistant, but sensitive to 1 or 2 drugs. And that's what we are seeing. We are not seeing MDR, we are seeing XDR. So this is rising. and it's a global crisis. By 2050, it is contemplated that people dying because of the antimicrobial resistance would be equal to people dying because of cancer. And WHO has also declared this as a priority. If you see the priority 1, critical, gram-positive, there is none, but the 3 bacteria, carbapenem-resistant Acinetobacter, carbapenem-resistant Pseudomonas, and the Enterobacteriaceae. These are the 3 groups of organisms which are rampant, and in India, the E. coli is 12 to 59% resistant to these carbapenems. Klebsiella pneumoniae, highly resistant pathogen, and 50% resistant to carbapenems. And the imipenem susceptibility to E. coli has really dropped from 86% in 2016 to 2021, this is 64%. This data is from the ICMR, which publishes data every 1 or 2 years about the prevalence resistance in our country. Acinetobacter resistant to carbapenem, 87%. So carbapenem, practically, if you isolate Acinetobacter, is most of the time resistant to the carbapenems. Benocycline resistant 50% to the carbapenems. And this is a comparison of the E. coli in different, and this is the published data from the ICMR. Amikacin has retained about 70% sensitivity to E. coli, and colistin, it is still 90%. Klebsiella, still colistin or the polymyxins have about 90% sensitivity. If you compare in UTI, they have seen the colistin is also losing sensitivity. It is below 90%, in the range of 80%. And similarly, TG cyclin. Hello? Battery has gone out. Battery. Battery नहीं है. Beta-lactamases, or the NDM, which was the production. The name is NDM because New Delhi beta-lactamases. And these are how the beta-lactamases has been growing, and 91 to 2009, where the metallo-beta-lactamase came into existence, and they are produced by almost all gram-negative bacteria, and they're resistant to all. Why do they develop? One of the reason is the previous antibiotic use. 91.1% people who have resistance, they already had the antibiotics. Previous carbapenem use, previous colonization, mechanical ventilation, dialysis, catheters, staying in the hospital, that's how people are isolated with the resistant pathogens. And there are different risk factors for different bacteria, like for Pseudomonas, structural lung disease. For Stenotrophomonas, previous use of carbapenem. So these are the risk factor for various organisms. And the ICMR has been publishing, and now they have recently published in March 2022, and it is available as an application which you can download, and most of my talk is from there only. ITSA also publishes the guidelines. The latest guidelines were published on 6th of July 2023 based on the prevalence of resistance. So what is the way forward? We have resistance, of course. So way forward is antimicrobial stewardship. What is this antimicrobial stewardship? This is that you select optimally. You have to increase your knowledge. As a physician, know more and more about the antibiotics. Give proper dosages for proper duration. That will result in the best clinical outcome for the treatment or prevention of infection. And give drugs with minimal toxicity to the patient and minimal impact on subsequent resistance. Give appropriate drugs, use PK/PD, and de-escalate when they are not required, and shorten the therapy of duration. These are the part of the antibiotic stewardship. And when you use this, it has resulted in improved antibiotic use. That means decrease antibiotic use and improve outcomes. These are the various components of antibiotic stewardship. Minimize the source of infection, and the most important is prescribe antimicrobial only when they are needed. So they found that 50% of the times the antibiotics are used inappropriately. Wrong drug, wrong route, wrong interval, and it has resulted in increased mortality, morbidity, increased length of stay, increased adverse events, and increased cost. The right antibiotic, right dose at a right time for right duration. So this is what is the most important aspects of antibiotic prescription. And they should be given if patient is in a septic shock within 1 hour of the arrival to the hospital, and within 3 hours if patient has sepsis. It is also important, since we are talking about carbapenem resistance, to diagnose carbapenem resistance. There are phenotypic methods, biochemical assay, and gene-based diagnostics, which you just heard. Phenotypic is like we normally antibiotic susceptibility test, which we do, and biochemical assay and gene-based diagnostic or the molecular test, which turnaround time sometime is within 2 hours. They give you the report that what kind of mechanism of resistance is, at least the gene-based, and you can choose the antibiotic appropriately. And they are fairly okay for the KPC, NDM, and OXA48, and IMP and WIM. And there are other biochemical assay and gene-based diagnostic tests are coming up in the diagnosis of the resistance so that you can appropriately change the antibiotic in your patients. Now let me give you an example that you have a bug, probably it is ESBL, OXA48 and NDM. Your lab gave you report and you gave ceftazidime, avibactam and aztreonam, but your patient is not getting better. The reason is this beta-lactamase is not the only mechanism of resistance. There could be other mechanism of resistance. And now more and more people are suggesting that you should do a synergy test. What is synergy test is that in the agar plate, they put the E strip, like you see, ceftazidime, avibactam strip, and along with this aztreonam strip, and you see an area of inhibition. That means this drug is effective. You can ask your microbiologist to do it, and it can give you result very quickly, and you know that probably your patient is going to get better with these drugs. Most of the time we choose antibiotics empirically, and they are based on your experience in that hospital, what is the local antibiogram, what is the exposure. If patient is on dialysis, he's coming again and again, he will be carrying the resistant organism. The organism identified earlier in the patients in the previous 6 months will also give you a clue what antibiotic to choose. There are certain organisms, when you isolate, please don't treat them. Acinetobacter, 80 to 90% of the time is a colonizer. It is not an organism which, if patient is all right, Acinetobacter and Stenotrophomas meltophilia, just throw the report. If patient has symptom, only then you treat these organisms. We have a lot of BLI. Our country is really full of. If you see on the right side, none of them is approved by FDI. They do a small study and introduce into the Indian market. And the other ones are the FDI approved. And we have never used the right one, even in a single patient. In our hospital, they are not allowed to enter. And out of these left ones, the last two are not available, meropenem vebrobactam and imipenem relobactam. We have ceftazidime avibactam. That's the only drug. The similarity between the BLI and carbapenem is they have the almost similar kind of coverage. The BLI do not have CNS penetration. If a CNS infection, BLI is no good. And it has no enterococcus coverage, which is present in the carbapenems. And now this beta-lactamase inhibitor, the avibactam, if it is combined with the ceftazidime, as you can see, except for the NDM, it is effective against all the carbapenem-resistant mechanisms. And the ceftazidime avibactam can be used in the complicated intra-abdominal infections, UTI, as well as the hospital-acquired infections. This has a long list where it is effective, but I think it is important to know where it is not effective. The ceftazidime avibactam is not effective in Acinetobacter, Stenotrophomonas maltophilia, Enterococcus, and MRSA and the MSSA. It is not effective drug. The ICMR has written guidelines for our whole country. Carbapenem test is not available everywhere. Small center, they have only phenotypic test. So they have said that when the carbapenem test is not available, how to choose antibiotic. So they have suggested that if it is a hemodynamically unstable patients, use polymyxin plus another agent to which organism demonstrates susceptible MIC like TG cycline, aminoglycoside, or phosphomycin, or high dose carbapenem, which if the MIC is less than 16. No longer use meropenem as a 1 gram 8 hourly. The current dose is 2 gram 8 hourly. It is the ITSA has suggested recently, and we've started using meropenem as 2 gram 8 hourly whenever you are using in your hospital-acquired infection. Ceftazidime avibactam can also be used if the test is not available. The other is TG cycline, but TG cycline, it is only approved for intra-abdominal and skin and soft tissue. It is not effective in bloodstream infection. It is not effective in UTI. It has not been shown to be efficacious in pneumonia. But in combination, we do use in pneumonias, but in UTI and bloodstream, it is really not effective drug. Then if you have the facility of carbapenem test, if it is metallo-beta-lactamase, the first drug of choice is ceftazidime avibactam. And now in the world, there is a drug called ceftriaxone, which is a very good drug. It will be introduced in Indian market very soon, and they are finding it to be good for even NDMs as well, ceftriaxone. But otherwise, if the other option, ceftazidime avibactam, is not available, the other option is polymyxin, along with another drug, which I just enumerated, like along with phosphomycin, aminoglycoside, or TG cycline. And if it's an uncomplicated infection, you can use aminoglycoside alone only. If it is a NDM, you always use ceftazidime avibactam along with aztreonam. You do not use ceftazidime avibactam alone if it is a NDM. It is always used with the aztreonam, and both should start simultaneously. If you do not start aztreonam at the same time when ceftazidime avibactam is given, it will not be effective, because the combination which is effective is aztreonam avibactam. So they have to be given together if you are using for NDM, ceftazidime avibactam along with aztreonam. That is the drug now has become the first choice. For combination, if OXA48 is also there, then also you have the similar choice. But if it is only OXA48, ceftazidime avibactam alone is enough. If it is KPC, then also alone is enough. But KPC is not a problem in our country. Now suppose you have an Acinetobacter. Now this is another organism. In certain hospitals you have Acinetobacter. High dose sulbactam. Any time I have Acinetobacter, none of my patient is without sulbactam. It is whether non-susceptible, in your culture sensitivity report still use sulbactam, but give 6 to 9 gram. If you are using MP sulbactam, the dose of sulbactam should be 6 to 9 gram. So it will, for an adult, it will be 27 grams of MP sulbactam, which you can give infusion over 24 hours. So this is the drug of, which is now becoming the drug of choice, sulbactam. Polymyxin can also be used, but if it is UTI, polymyxin B does not penetrate to UTI. Use colistin. Whenever you have UTI, change polymyxin B to colistin, because polymyxin B doesn't go into the UTI. It is the only colistin, or which is also polymyxin E. Minocycline or TG cycline. These are the drug which you can use for Acinetobacter. You can give in combination. If patient is very severely ill, you can give combination sulbactam along with another drug in moderate to severe crab infections. Nebulized antibiotics have absolutely no role. Stop using them. They have been found that they need to be stopped. Only condition where nebulized antibiotics are effective is bronchiectasis patient, chronic bronchiectasis patient, or cystic fibrosis. In the hospital-acquired infection, nebulized antibiotics are totally out and they are not recommended now. Then for the carbapenem-resistant Pseudomonas, again you have a combination is suggested along with ceftazidime avibactam along with a combination, or polymyxin along with aminoglycoside or phosphomycin can be given in these patients. Then the other is to give a proper dosages. Now the dosage recommendation recently have changed. Like I said, for MP-sulbactam, 27 grams you can give in infusion, or you can give 3 grams of MP-sulbactam every 4 hourly. For ceftazine avibactam, the dose is 2.5 gram IV 8 hourly, infused over 3 hours, plus aztreonam at the same time, 2 gram IV 8 hourly. If you are using ciprofloxacin, 750 milligram, 12 hourly, rather than 500 or 400. Meropenem, that's a major change, 2 grams IV every 8 hourly. TG cycline, if you are using 200 milligram, not 100 milligram, 200 milligram IV as a single dose and 100 milligram IV over 12 hours. If you see the Western guidelines, they are discouraging the use of polymyxin. They are saying that it's a toxic drug, and they really don't know what is the breaking point, because MICs are increasing. You will always find intermediate sensitive. You will never find susceptible report because the MIC is increasing. And if you see ITSA guidelines, polymyxin B doesn't, nowhere it is there. It is Indian guidelines, and we still have, it is a comparatively cheaper drugs. Now even the ceftazine avibactam has also become cheaper. Probably the polymyxin B use will also go down. Then the polymyxin B, if you are using, always give 15 lakh as a bolus and 7.5 12 hourly. You need not change in renal failure, because that's it. We write down and nephrologist comes and reduces the dose. It is really not required. It is a nephrotoxic drug, but in AKI the dose need not be changed. Colistin you have to change, 9 million, 4.5 12 hourly, and you have to change the dose. If it is an uncomplicated cystitis and patients had a carbapenem resistance, simple drugs like nitrofurantoin and trimethoprim, sulfamethoxazole are good drugs. You need not go into higher. If patient has pyelonephritis or complicated UTI, then you have to follow what I said and all other infection. But for you, simple uncomplicated cystitis, you can use oral phosphomycin as a single dose or aminoglycoside, nitrofurantoin, if there is a sensitivity in your culture sensitivity report. Then nowadays, beta-lactam, they are suggested to give in the infusion form. You should give them, because if they are not susceptible, if you maintain the level, the MIC will remain high and it will cover it. That's the purpose of giving in the infusion. All these beta-lactams and beta-lactam inhibitors preferably given in the infusion form. Doripenem is not given as a prolonged infusion. Doripenem has to be given, all other carbapenems are suggested to be given in the infusion form. And use the pharmacokinetic principle. Whether your drug penetrates to the site of infection. Daptomycin for lung is not good. TG cycline for urine is not good. The polymyxin B for urine is not good. So you need to know the pharmacokinetics and pharmacodynamics for the drug to be effective. Once you have started, now this is a problem, that you start meropenem with teicoplanin, your patient is better, let me not de-escalate, report is shining, E. coli sensitive to carbapenem. You see, we need to de-escalate, narrow the spectrum of the pivotal antimicrobial, or if you discontinue one drug out of the combination, or the double cover you are giving for one antibiotic, or coverage of non-isolated pathogen, these two are the component of de-escalation. That is what a de-escalation is. And the penem and meropenem you were given, and you find ertapenem is also sensitive, you de-escalate to ertapenem. Similarly, you found that you are giving vancomycin, and it is sensitive to cloxacillin staph aureus. You de-escalate. That is what is a de-escalation. Then the other also very important aspect of the antibiotic stewardship is not only the uphold the surveillance, local antimyogram in connection with the microbiologist. You should regularly see what is the sensitivity pattern, monitor the antimicrobial consumption. Now a good hospital is known, in our hospital monthly how much antibiotic were consumed, and the next month how much antibiotics are consumed. This also tells how good is your antibiotic stewardship program, how you are decreasing the antibiotic usage. Then automatically 10 to 14 days, please stop following for antibiotics, because everything started 10 to 14 days. Now it is suggested that give what is recommended. Ventilator-associated pneumonia, 7 to 10 days. Complicated urinary tract, 10 days. Catheter-associated UTI, 5 to 7 days. Intra-abdominal infection, 4 to 7 days. I feel very happy because surgeon is very aggressive in stopping antibiotics. Central line-associated bloodstream infection, 10 days. Then the infection control. That's a very important component of the antibiotic stewardship. You know, we will use the best antibiotics, but we are not teaching our nurses. We are not spending 5 minutes in the ward that how to clean, and we don't set ourselves as an example. And our hands are responsible many a time, full of flora once you examine. Let me show you an example. I've examined this patient A. He has infection all over. And now I go to patient B and I spread that. That's how the infection. So I think infection control practices, bundle practices for suctioning, bundle practices for catheter-associated infection, for UTI, and somebody has to take a lead. You may not be in charge of ICU. Take a lead and start doing, because physician is the most sufferer if there is antibiotic resistance. And antibiotic stewardship can be when patient comes, it can be done during stay, it can be done during discharge. Because when he's going home, see that whether I can change it to an oral and make his life easier. So stewardship is at every level. Make a team in your hospital. An ID physician or any physician, intensivist or physician can be a leader, clinical pharmacist, clinical microbiologist, infection control nurse, and hospital administrator. Every hospital can easily do the antibiotic stewardship team to monitor that. You know, in our hospital, if I write down ceftazidime avibactam, I have to call a microbiologist to get it. We don't get ceftazidime avibactam without her approval. I have to say that this is there. And she's available all the time. First dose is available at night, but second dose, we have to get her permission. So to conclude, antimicrobial resistance is rising. It's not a big science. Carbapenem resistance has acquired high proportions. Carbapenem-resistant Enterobacteriaceae, carbapenem-resistant Acinetobacter, carbapenem-resistant Pseudomonas, Stenotrophomonas maltophilia are the gram-negative pathogens which have really become difficult to treat pathogens. Molecular diagnostic and phenotypic method should be used, because if you save a patient one day in the hospital, that covers the cost of your biofire. So sometimes we say that at one go 20,000, but sometimes if you can discharge patient one day early, it will save much more. Microorganism may have multiple mechanisms of resistance, so synergy test, ask your microbiologist to do a synergy test. Empiric therapy should be selected on the basis of local antibiogram, comorbidities, and pharmacokinetics. Polymyxin B, probably when you talk after 3 years, it would not be in the up, but it should be not be used in UTI. If you want to use it UTI, use colistin. And do not change the dose of polymyxin B in AKI. Colistin dose has to be changed in AKI. TG cyclin should not be used in UTI, bloodstream infection and pneumonia. Daptomycin should not be used in lung and BLI in CNS infections. Prescribe in appropriate dose and route. Beta-lactam antibiotics work better in infusion form, except for the doripanum. Antibiotics should be used as prescribed duration, not because of 10 to 14 days. Infection control, including hand hygiene, should be given high priority to prevent infections. So antibiotic stewardship is only the way forward to improve outcome of antimicrobial resistance. Thank you very much.
I request all the guests for the oration to kindly come over to the stage for a group photograph, and rest will be dispersing for lunch, and we'll be meeting at around at exactly 2:25, 30 minutes from now, to begin with our post-lunch sessions.
For this neutropenia, is it drug-induced neutropenia, or it is the disease per se which is causing the neutropenia. So whenever we are encountering patients with neutropenic fever, so if you see the global guidelines and which we follow in our countries as well, that febrile neutropenia patients should be considered as critical patients, even if they are vitally stable. And one caveat in this come of a patient who is neutropenic. So it is not only fever, that is my first point. So usually we say it is prolonged neutropenia when the absolute neutrophil count is less than 500 for 7 or more days. And if it is less than 100, we call it profound neutropenia. So in case of profound neutropenia and also in case of severe neutropenia, if the patient is showing any sign of infection, no, I will not say it is fever, so we should deal these patients with caution. And there is a very commonly used triage model of these patients whenever you encounter these patients in your day-to-day practice in emergency department, and even in patients, that you should triage those patients based on, there are some scoring systems also, that high risk, moderate risk and low risk patients, that you have to triage and you have to think about that what are the antimicrobial cover you should start in these patients. So there is a question that do all patients of febrile neutropenia require hospitalization? So as far as the guidelines are concerned, no. That if the patients are not in sepsis, or these patients who are not showing any systemic signs of sepsis, you can manage those patients in OP basis also. You can monitor those patients in your OP or ER to run a few tests to rule out extensive involvement in in different organs. If the sepsis is limited, I'm just giving an example that during this dengue season, one patient with neutropenia who recently underwent bone marrow transplant, he came to your OPD and he's showing that it's an acute onset high-grade fever. So during these rainy seasons, you can very easily run a few tests if it comes to be malaria or it comes to dengue. So it is a boost for the treating team that that person is not having a serious bacterial infection, that it can be managed. So in cases of febrile neutropenia, not always that you have to start antibiotics right on, but you have a timeline. You have a timeline of 60 minutes. So whatever you have to do, whatever you have to start, your broad spectrum antimicrobial therapy, the judgment should be taken within the first 60 minutes of hospital, first 60 minutes of arrival to your healthcare facility.
So my next question is, what are the appropriate antimicrobial coverage in patients who are having febrile neutropenia and they are hospitalized?
So in this question, I just want to highlight a very important thing, that regarding choosing an appropriate regimen of a patient with neutropenia, we should not blindly follow the Western guidelines. As in many of the guidelines, you will find that patients who are having neutropenia and having fever, and even in the prophylaxis of neutropenia, they are suggesting fluoroquinolones, levofloxacin, ciprofloxacin. But we have to understand why fluoroquinolones, why these drugs are prescribed to as a prophylaxis or as a treatment, whatever it is. So I just want to give a message here that regarding fluoroquinolones. So in case of neutropenia, the main problem is our gut flora. So patients who underwent radiation, who underwent chemotherapy, in many of the cases we see that there might be radiation-induced mucositis, or in due to immunosuppressed state, the gut flora is not protecting us from the pathogens, and even the commensals we harbor in our GI tract, due to the disrupted GI barrier, they are getting translocated inside into our bloodstream. So our own commensal bacteria is causing bacteremia. So it is a GNB bacteremia, gram-negative bacteremia. So if you follow the nature of gut microbiota in Indian population, So you will find that more than 80% of patients, they are harboring ESBL producing bacteria, ESBL producing E. coli inside our gut. And I am pretty sure that if you see the data from all over, all the corners of our country, that the rates of fluoroquinolone resistance is very, very high, considering our own gut flora. So there is a very controversial role of fluoroquinolone prophylaxis and fluoroquinolone treatment in case of neutropenic fever in our country. So the confusion fades away when there is a severe infection in case of high-risk patients. So there is no role of fluoroquinolones. So you can straightly start those patients with either carbapenem or a beta-lactamase inhibitor combination. And also, if you are suspecting MRSA, if there is patient is having some risk factors for MRSA infection, you can straight go to either vancomycin. It is always a preferred drug for MRSA, or you can give ticoplanin. And also, we have to think about a lot of many other causes. It can be fungal, it can be yeast, it can be molds. So whatever cover your ancillary tests and your radiology and the routine tests suggest, you have to treat those patients in an individualized approach.
Thank you, Dr. Kashnil. Now, the next question is to our nephrologist, Dr. Dilip Balla. What are the common infections in the CKD patient and in patients who are on dialysis?
So thank you, Dr. Vijay. These are the three questions that I had put up. So I'll take the second one, the symptoms of infection and how do they differ in the immunocompromised host. I think the topic is fever. So in an immunocompromised host, you must understand that only 40% of patients have fever, 60% of patients don't have fever. So fever is not always present in patients who have infection, but the other subtle signs are very important. These signs being, patient he may be obtunded, he may be losing weight, he has fatigue, he has hypotension on presentation, you do an LFT, he has deranged LFT. So these are the signs that you'll find more commonly in our patients who are immunocompromised. Right, now because the patients are immunocompromised, you will have to investigate these patients in a different way. And we look at patients of chronic kidney disease. Now chronic kidney diseases again can be patients not on dialysis vis-a-vis patients on dialysis. Patients who are not on dialysis, they are more prone for community-acquired pneumonias, more prone for urinary tract infections. On dialysis patients, because they have lines, if they have a catheter, they are more prone for catheter-related bloodstream infections or infections that one gets basically because of the dialysis lines that are being there. So a patient of chronic kidney disease not on dialysis, think of community-acquired pneumonias, think of urinary tract infections, and on patients on dialysis, basically catheter-related infections. The organisms basically are gram-negative organisms and UTIs, as well as, and for the lines, we suspect patients having staph. Basically, it may be a MRSA or maybe a resistant or a sensitive organism that is there. Now, coming to the second part is the patients who are immunocompromised, especially dialysis patients or patients on transplantation. What is important is that one must realize that the routine investigations, cultures may be positive, may not be positive, but the way to go about these patients is that you try and identify the organism, and the way to identify the organisms is ideally try and get your basically serologies will not be helpful, so you have to go in for antigen-based studies. I think Dr. Salab just mentioned the role of biofibers. That is extremely important, antigen-based investigations along with nucleic acid-based. Secondly, radiology plays a very, very important part in localizing the infections. So extensive use of CT scans, MRIs, and PETs. Thirdly, the other important thing is you have to try and do invasive investigations. Histopathology will tell us at times as to what is the organism. We have had patients of chronic kidney disease coming to us with weight loss. We've got PET scans done. We find nodules in the lung. We do an FNAC, and we grow fungus in that. So these are just simple examples, and this is how one must understand. This is the way to approach these patients. That fever is not always present. Other signs and symptoms must be looked for. The organisms you should be aware in patients for chest infections as well as for patients with urinary tract infections. the fourth important thing is to investigate, try and anatomically localize the infection, go in for invasive tests. If you cannot identify the organism by your blood tests. Sixth is that go in for, rather than the normal cultures and serologies, go in for antigen-based tests. And seventh is that keep your mind open to both the common as well as the common organisms. The common organisms, as has already been discussed, you may have your ESBLs, you can have your staph. Uncommon organisms depends upon what is prevalent endemically. If you have endemic fungi and you have endemic viruses, this is there extremely important that you should look into that. And the other thing is that you must individualize the treatment in this class of patients. So this is basically how we manage our patients who have got, who are immunocompromised with chronic renal failure or going or for patients with transplantation.
But Valla, next query is what precautions do we take in managing these patients on the outdoor basis?
So the precautions is that if you're having a patient, first of all, I would like to talk about organ donation. Now, if a patient is an organ donation patient, you must try and see that he has adequate prophylaxis. Now, the adequate prophylaxis, what we mean is that we are looking at basically prophylacting these patients by giving them Septron. Now, Septron is a very good drug to look after a lot of organisms. Basically, your urinary tract is looked after, your pneumocystis is looked after, plus the other organisms. Plus, in addition to that, these patients are very much prone for viral infections. The viral infections that commonly occur in our patients is cytomegalovirus, plus they can have the herpes simplex group of viruses. So these patients, we take adequate precautions by giving them a good cover with antiviral. The most common antiviral that we use is valganciclovir. So the prophylaxis in this group of patients is Septron with valganciclovir. The duration varies between 3 months to 1 year. This is very good prophylaxis that is to be given in our group of patients. Patients of dialysis and patients who are chronic kidney disease, the dialysis, I think Dr. Chawla very nicely mentioned, is that antibiotic stewardship is very important, plus the care of these patients is very important, that the dialysis unit should be sensitized as to avoid any nosocomial spread of infections, adequate care of the catheters, and patients of chronic disease should avoid going to places which are extremely crowded or coming in contact with patients who are having this kind of infection. So this is how we go about managing these patients on an OPD basis.
So the next is timeline and the risk factor in the post-renal transplant patient.
So post-transplant patients, basically we have 3 timelines. One is the immediate 1 month of post-transplant. Then is the intermediate, that is 1 to 6 months. And the last is the delayed. The first 1 month is the infections could be donor-derived or because of the surgery that is being done. The donor-derived could be anything that patient, any infection that is got from the donor, or if the patient is harboring some infection which has not been cleared. And the surgical line, if there is a change in anatomy, there may be a surgical line infection. This is what we see in the first 1 month. Between 1 to 6 months, that is the time when the immunosuppression is at the maximum. So this is the time when patients are very much prone for your viral infections, cytomegalovirus being the most common, plus you get fungal infections during this time. Pneumocystis may be also there. And after 6 months, when you're cutting down on the immunosuppression, it is more of a community acquired. So the first 6 months is the most important period for our transplant patients, where there should be active surveillance for any infection. And there has to be a very fine balance between adequate immunosuppression as well as infection. So doing drug levels, monitoring these patients by drug levels is a very, very important part of our armamentarium in managing these patients. We have to optimize the drug therapy and see that these patients are not prone for any of these infections. After 6 months, the general rules are applied, and we have to look out for community-acquired infections. So this is how we go about looking after our patients.
So this question you have answered, then the role of prophylactic medicine in patients undergoing dialysis and transplant.
Yeah.
You have adequately answered this question.
Yeah.
Thank you, Dr. Bhalla. And next question is Dr. Satinder. The risk factor of infection and any timeline of type of infection in post-liver transplant patient, is there any difference in the risk factors and the patients of post-liver transplants versus post-renal transplant?
Thank you for the questions. So risk factors for post-liver transplant starts from the donor. And so we do usually serological markers in donor and identify those have CMV or EBV, IgG or IgG levels. those who have donor positive and recipient negative, they have the highest risk factors of transmitting infections. Intermediate being the risk factor being positive, and lowest risk for the donor is negative and recipient is negative for the infections. Then coming to the surgery, the duration of the surgery, prolonged hospitalization because of the immunosuppression, patients needing methylprednisolone pulsing doses for the recurrent graft dysfunctions. Those patients who have early allograft dysfunction requiring plasma exchange and extracorporeal therapies like CRRT therapies and other ventilators, prolonged ventilation, those are also at high risk factors. In liver transplant, specifically ABO incompatible liver transplant is coming up, and we do give them rituximab before the transplant. So they also are very at high risk of developing infection in post-transplant period. So these are the main risk factors, and timeline is correctly given in tables. Less than 1 month is predominantly surgical related, and if we differentiate from renal transplant, then we have biliary anastomotic strictures most commonly, and where we do add the bile ducts, and so whatever is infections due to biliary anastomotic stricture, there are risk of cholangitis. So cholangitis are gut-driven. Usually E. coli and Klebsiella pseudomonas are the most common risk factors in post-liver transplant, if we differentiate them from the renal transplant. And next question, I think I have answered.
Any difference in the spectrum of infection in immunocompromised and immunocompetent patients with liver disease?
Yes. So in immunocompromised, like in liver transplant, we do give prophylaxis. Fluconazole prophylaxis is given, Septran prophylaxis is given, and Valgan prophylaxis is given for the CMVs. Pneumocystis is covered with the Septran, and other fungal infection and Isospora, Cryptosporidium, they are also covered, and fluconazole for the antifungal. So these infections are covered with the immunocompromised in liver transplant patient. Apart from that, in immunocompromised, there are risk of the capsule organism to be more causing the infections like Pseudomonas and Klebsiella, Staph aureus, VRE also. Coming up, carbapenem resistant Enterobacteriaceae is also very much coming up, apart from ESBLE, which has been discussed. So VRE, MRSA, CRE, carbapenem resistant Enterobacteriaceae, and ESBLE are the more common.
So what are the common bacterial, viral or fungal protozoal infections which are patient in liver transplant?
It's been done already. I explained the bacterial same. Viral maybe CMV, EBV, and HSV, human herpes 6, 7, and adenovirus, influenza virus, they are more common. And so we do prescribe the patients to vaccinated for the influenza and pneumococcal vaccines. So these infections are very common. In the fungus, we have Cryptosporidium. In the fungus, we have Aspergillosis, Nocardia. They are very high risk organisms, and apart from that, Candida is also always there. And in protozoal infections like Toxoplasmosis and Giardia, Cryptosporidium, Isospora, they are very much resistant, so we have to cover them.
Thank you, Dr. Sindar. The next question is to Dr. Meenu Walia. What is febrile neutropenia? How do you define febrile neutropenia? Why is it significant concern for cancer patient undergoing chemotherapy? And how does the management of febrile neutropenia and the cancer differ based on the type and the stage of the cancer?
So febrile neutropenia, by definition, as the name suggests, is fever in a neutropenic patient. So any patient, whenever we talk of fever, we are talking of oral temperatures in these patients. So any patient having a temperature of more than 101 degree Fahrenheit at any point of time, or a temperature greater than 100 degree Fahrenheit, which is sustained for at least for 1 hour, in a patient with an absolute neutrophilic count less than 500 cells per cubic millimeter. So this is what is the basic criteria to categorize it as febrile neutropenia. ANC has to be less than 500, and temperature has to be either a single episode documented to be more than 101, or if it is 100, more than 100, that it should be at least for a period of 1 hour. So that is how we define febrile neutropenia, and it becomes a matter of great concern for patients undergoing cancer treatment. Any patient during the course of chemotherapy, in case they have febrile neutropenia, apart from all the other people who have said about it, febrile neutropenia is actually a medical emergency and needs to be tackled accordingly. Apart from the management, what is also important is a significant time is lost for the management of febrile neutropenia, and the result is that even when the patient comes out of it, the next cycle of chemotherapy will be delayed, or we need to compromise the next cycle of chemotherapy. The dosages have to be compromised, and it may indirectly impact whatever you are going to get from the chemotherapy. The cure rates may be impacted. That is why it is very, very important that febrile neutropenia, if already predicted, because some of the chemotherapy protocols we know that have a 40% chance of having febrile neutropenia. So we go for prophylactic growth factors in those group of patients. So you said is how the management will be differed depending on this type and stage of cancer. So if it is an early stage cancer, where you are giving chemotherapy in a curative setting, where you expect the patient to survive, here you do not want to compromise the chemotherapeutic dosages, nor do you want to delay the therapy. So here what you need to do is, we normally go for prophylactic growth factors, and even if the patient has febrile neutropenia, you aggressively manage with growth factors rather than compromising the dosages. However, if it is a stage 4 patient, post multiple lines of therapy, in a palliative setting, patient develops febrile neutropenia. Here it is easier for us as clinicians to take the call of compromising the chemotherapeutic dosages or delaying the chemotherapy. Here we definitely decrease the dosage in the next cycle by more than 25%, because aim is not cure, aim is more like making him live longer, and also the aim is about quality of life in this group of patients.
And do we need antimicrobial prophylaxis in metastatic solid organ cancers?
Not in all metastatic solid organ cancers, but in certain type of cancers when you are going for certain types of protocols. For example, in breast cancer, if I am doing a normal chemotherapy, I don't need any antibiotic prophylaxis. But in a breast cancer, the same breast cancer patient, suppose the patient is a triple negative breast cancer, and I am going for a dose-dense chemotherapeutic protocol, where we know that the risk of neutropenia is more than 40%, here definitely some kind of oral prophylaxis will be required.
Does the presence of CVAD change your antibiotic preference?
Yes. So, I mean, generally, what you expect is most of the infections are gram-negative sepsis, which are more common in these patients. So, your initial antibiotic preference is always something which is covering a gram-negative coverage. So, in a patient who has a CVAD, we need to add a step up further. A gram-positive coverage should definitely also be added as part of the treatment.
Any role of antifungal in prophylaxis?
Normally no, not for solid cancers, but some kind of hematological malignancies, we definitely give antifungal prophylaxis also. And for management of febrile neutropenia also, if the patient not responding to antibiotics for more than 48 hours, remaining febrile, the recommendations say ki add up a antifungal also.
Thank you, Dr. Meenu. And the next question is Dr. Akash Neil. What are subtle signs in pregnant female with fever requiring close attention?
Yes, so pregnancy is a state when you are dealing with two lives, right? So in pregnancy, wherever you are having an infection, you are getting some signs of the mother, right, in clinical examination. So it is always advised whenever a pregnant female is having fever, we have to understand and we have to analyze the etiology of fever. So you have to consult a specialist to find out the etiology, whatever it is. It can be even non-infectious causes of fevers. Certain autoimmune diseases, they flare up during pregnancy, and which is associated with adverse pregnancy outcomes. So you have to be very watchful, like what is mentioned, that there is a subtle signs of different viral infections like CMV, parasitic infections, toxoplasmosis. CMV congenital CMV is very uncommon in our country, as many of the pregnant females, they have acquired the primary infection. So it is more common in countries where the CMV is less prevalent, less seroprevalent, I would rather say. So that is the thing, that we would be very much watchful of in pregnancy, that we are not missing any cause of fever which can cause adverse pregnancy outcomes. So the next question is the role of adult vaccination. So there are a lot of vaccines which are available today even in our country that is strongly recommended as vaccinations in immunocompromised hosts. So just for an example, there is a vaccine that is the Shingrix vaccine, that is vaccine against shingles, that is herpes zoster. That is a recombinant vaccine, very much effective. It prevents the single episode of shingles or recurrent episodes or disseminated infections. So a lot of vaccines like hepatitis B, A, whatever you know, and added to it many more. The concept here is whenever you are starting planning a treatment for any cancers like hematological malignancies or solid organ cancers, you do not know what your line of management will lead you to. So in case of non-responsive cancer, non-responsive to treatments, down the line you do not know, after 2 years you will use some immunotherapy which might reactivate some latent viruses like in hepatitis B. So we did not used to test every patient for hepatitis latent, that is occult hepatitis B. So nowadays we are in the rituximab era. So all patients are tested for occult hepatitis B infection. So whatever the vaccines available, and most importantly, not the live attenuated vaccines, all the inactivated vaccines that are preferred, considering the immunocompromised state. Yeah.
Thank you, Dr. Kashnil. And my request to both the chairpersons to summarize this and have any question, because
I think it's all very elaborate discussion on various situations. And only thing I would like to add rather with Dr. Meenu Walia's discussion, that immunotherapy is latest in the chemotherapy. And I think the immunotherapy is developing because of the immune status and from the antibiotics only. So what is your comment about antibiotics in cancer? Is it in development of immunotherapy, or as such also the antibiotics, they help in the treatment of cancer?
We generally do not use antibiotics in the treatment of cancer, and the concept that immunotherapy is now being used in cancer is entirely a different kind of a concept, because what normally happens is your normal immune processes of your body, your cytotoxic T cells are not able to recognize the cancer cells as foreign cells. They recognize as self-antigens and not able to develop the immune responses against the cancer cells. So whenever we give these immunotherapy, the so-called immunotherapies, which are basically monoclonal antibodies, which are generally anti-PD-1 or anti-PD-L1 blockers, which unmask the cancer cells to the cytotoxic T cells of the body. So this is how immunotherapy works, and fortunately for us, immunotherapy doesn't cause neutropenia. So these patients are not at risk of febrile neutropenias and not at any higher risk of infections than a person with any other patient with cancer, like not undergoing chemotherapy, as good as not undergoing chemotherapy. And apart from the fact that these immunotherapies work wonderfully well in some group of cancers, that is another reason, because febrile neutropenias, this doesn't happen, no need of monitoring. That is the reason that immunotherapies are gaining acceptance in the oncology world.
Thank you.
So it will be fair on my part to just conclude the session here. We have already shoot by 15 minutes, and thanks panelists for a wonderful session. You are very, I think, useful opinion on different aspects. So round of applause for panelists and moderator Dr. Vijay Arora. So I'd like to conclude. We are already overshoot by 15 minutes. Thank you very much.
Yes, sir, please. So we'll discuss, I'll discuss with you, sir. Yeah.
Thank you, sir. Now I request the panelists and chairperson to kindly proceed to the felicitation desk. I request Dr. Ashok Grover to come over to the stage to start with the next session. I request Dr. Aman to felicitate the faculty.
So after this hectic discussion on various clinical situations and the antibiotic therapy, now we have a session on hand, and the topic is now approach to non-resolving pneumonia. And I invite the chairpersons on the dais, Dr. Vijay Arora, Dr. Sharad Joshi, Dr. S.K. Bakshi, and Dr. Aman Rohtgi to be on the dais. And I think we all know our chairpersons very well. All of them are renowned physicians in different parts of Delhi. And I invite Dr. Randeep Guleria, who is at present chairman of the Institute of Internal Medicine and Respiratory and Sleep Medicine and director of medical education in Vedanta. And I think he doesn't need any introduction. And without wasting much time, I request him to deliver his talk. Dr. Sir.
Thank you, Dr. Grover. And I'd like to start by thanking the organizers for inviting me to deliver this talk. And I'll be talking in a very simple way of how do we approach a patient who has non-resolving pneumonia. So what is non-resolving pneumonia? Slowly or incomplete resolution of a pneumonia despite adequate treatment would be a simple way of saying what is non-resolving pneumonia. It's common in clinical practice. If you look at consultations, almost 15% of inpatient pulmonary consultation are because pneumonia is not responding. Studies suggest that almost 8 to 10% of bronchoscopies are done with the diagnosis of non-resolving pneumonia. And there can be many reasons for non-resolving pneumonia. A wrong diagnosis, complications, host factors, mechanical factors, and sometimes pneumonia may not be because of an infectious cause. So again, what is the normal duration of resolution of pneumonia? And this is something that we need to understand before we say this is a non-resolving pneumonia. And this is difficult to define and it's highly variable. If you look at how does a pneumonia respond that is being well treated and is responding to treatment, normally tachycardia and hypotension usually settle within 2 days' time. Fever usually settles on the 3rd day with tachypnea, respiratory rate coming down, oxygen saturation improving, and cough may persist for 2 weeks. In certain viral infections, the cough may even last for 4 to 6 weeks. Fatigue can last for 14 days, and the chest X-ray resolution sometimes takes 4 to 6 weeks. So this is the normal evolution that we see as far as the pneumonia is concerned. But when do we say it's non-resolving pneumonia? So there's no real consensus. An old definition said pulmonary consolidation going on for more than 21 days. Kirtland and Wittenberg actually put in a definition of less than 50% radiological clearing by 2 weeks or less than complete clearing by 4 weeks, because it was felt that by 4 weeks' time, the X-ray should actually come almost back to normal. If you remember the basic pathophysiology of pneumonia, it goes through various stages of so-called hepatization and total resolution occurs. More recently, and a more accepted terms is what was put by Fine et al., who also came up with the pneumonia severity scores, that focal infiltrates clearly beginning with some clinical association of acute infection. So you have to have fever, expectoration, malaise, and dyspnea, but which does not resolve in the expected time. So it was very open-ended, and it said that you needed minimum of 10 days of antibiotics. This has changed to 5 to 7 days, but usually subjective improvement occurs within 3 to 5 days, and radiological clearance should start happening to a large extent by 3 to 4 weeks. So this is a rough way of saying that if a patient is not improving by the 5th day, X-ray has not improved by the 3rd to 4th week, you would actually start worrying and think of some factors for non-resolving pneumonia. So is it really non-resolving? Because like I said, radiological resolution takes time, and sometimes the picture may persist and patient may come back to you reading the X-ray report and saying, the shadow is still there, my pneumonia is still persisting. So it's important to remember that sometimes infiltrates actually may worsen on treatment because of an immune reaction. 50% of resolution occurs by the 2nd week. Usually 70% will occur by the 4th week. and more than 80% of resolution on the X-ray usually occurs by 6 weeks. But what are the factors which actually contribute to a delayed resolution and which you need to keep in mind? And some of them we discussed in the previous session: associated comorbidities. A patient with CKD or a patient with chronic liver disease or who is immunosuppressed will have a delayed resolution as far as pneumonia is concerned. The age, elderly people will also take a longer time for resolution. The severity of pneumonia, the etiology, and if it's a multilobar pneumonia, all of this take a longer time to resolve. So there are certain comorbidities which will delay the resolution of pneumonia. COPD is one because it leads to impaired cough and mucociliary clearance. Alcohol use disorders because they predispose a person to aspiration, malnutrition, neurological diseases, heart failure, CKD, malignancy, HIV, and diabetes. All of these, because of the fact that they have an effect on the immune system, mucociliary clearance, or have other effects as far as the lung is concerned, actually lead to a delay as far as pneumonia is concerned. So these are factors you need to keep in mind when we look at non-resolving pneumonia. Only about 20 to 30% of patients with comorbid conditions will have radiological resolution by 4 weeks. So if you have a person who has these disorders, keep in mind that the X-ray may take a longer time to resolve, and that doesn't make it a non-resolving pneumonia. The other factor is age. Radiological clearance by 4 weeks in the absence of comorbidities usually occurs. In a younger age group, more than 90% of patients will show clearance, but in the older age group, it may take a longer time. Severity of pneumonia is another important factor. If you have a mild to moderate pneumonia, it should resolve by 3 to 4 weeks, but severe pneumonia may take up to 10 weeks. The other factors is the organism which is causing the pneumonia. Remember, all organisms don't resolve in the same manner. So the organism is something that you need to keep in mind. Organisms where the pneumonia responds quickly are Mycoplasma, Chlamydia, non-bacteremic Streptococcus pneumoniae, and Moraxella catarrhalis, the common causes that we tend to see. But there are other causes which take a longer time. Bacteremic pneumococcal infection may take 3 to 5 months to clear. Legionella may take 2 to 6 months to clear. And Staph aureus and gram-negative infection also may take a longer time to clear. So it's very important to remember that once you look at, if you know the etiology of the pneumonia, some of them may take a longer time to resolve, and your X-ray may show shadows even for up to 3 months, and you should not get worried that this is something else that is happening, and therefore you should start now aggressively treating the patient. But if you have got a definite case of non-resolving pneumonia, then 3 major factors you need to consider. Is your treatment and diagnosis correct? Are you treating the right organism? Have you made a correct diagnosis? Then you need to look at the host factor. Are there some local causes which are impairing the resolution of the pneumonia? Is there a systemic cause, diabetes, which is not properly controlled, underlying CKD? Or is this pneumonia actually a non-infectious etiology and you're actually going down the wrong path? So these are 3 broad pillars that you need to keep in mind when you're looking at a person with pneumonia that is not resolving. So the first thing is consider resistant pathogens and inappropriate antibiotics or dose. Important consideration for any pneumonia that is not responding is, are you actually giving the right antibiotics? Is the bug sensitive to them? And is the diagnosis correct in terms of the etiology? We are seeing a lot of resistance, and we've had sessions on antimicrobial stewardship because resistance is gradually increasing as far as multi-drug resistant pathogens is concerned. We have penicillin resistant Streptococcus pneumoniae. Most strains of Streptococcus pneumoniae are penicillin sensitive, but there are now pockets being reported where penicillin-resistant Streptococcus pneumoniae is being reported both from Europe and from parts of Asia itself. We have multi-drug resistance, H. influenza, Pseudomonas, MRSA, and MDR tuberculosis. All are organisms which need different type of treatment because of the resistance. Then the wrong diagnosis. In our country, often tuberculosis. You could even have a lower lobe involvement in tuberculosis in a diabetic, and that could look like a pneumonia, but unless you suspect that, you will miss the diagnosis. And sometimes, unfortunately, these patients have got a quinolone or a fluoroquinolone for treatment of pneumonia, and that also causes problem, and therefore it masks the underlying tuberculosis, and it further delays the diagnosis of pneumonia. Fungal infection, pneumocystis, nocardia, and rupture hydrated are other common causes that one needs to keep in mind. So this is just a case, a 50-year-old male presented with fever, cough, and had hemoptysis for 3 weeks. He was a diabetic with poor control. He came with this X-ray, and a sputum which was sent for culture was negative, and AFB was also negative, and he was then started on parenteral antibiotics with the diagnosis of a necrotizing pneumonia. This is the CT of the same patient, and you can see this thick-walled cavity with a lot of necrotic material inside it. And this is another picture of the same CT. A bronchoscopy was done in this patient. It showed nodular and inflamed bronchial tree. A bronchial biopsy showed fungal hyphae compatible with cryptococcal disease, and this patient actually had cryptococcal pneumonia, which was an opportunistic infection because this patient was a diabetic. So it's important to keep unusual infections in mind when you look at the history. Most common in our country is mycobacterium tuberculosis. It's not unusual in India. Older adults, HIV positive patients, patients with diabetes, something that you need to keep in mind. NTM is the other common pathogen that you need to keep in mind, especially if you have infiltration in the middle lobe or the lingular lobe or a consolidation there, keep that in mind. Then nocardia, actinomycosis is something that you need to keep in mind, especially if you have a person who has very poor dental hygiene and chances of aspiration are high. And then depending upon the history of travel or where the patient has come from, sometimes that is also important to keep in mind, especially when you're looking at different etiology. For example, histoplasmosis tends to happen more in people coming from West Bengal because of the the Gangetic plain, where histoplasma is seen much more commonly. Then one needs to look at host factors. The first is local factors and then systemic factors. Local factors could be ineffective cough. Patient is not able to cough properly. Delayed or absent mucociliary clearance, seen very much in the elderly, and that can lead to persistence of the infection. Then you could have a local obstruction. It could be an intraluminal destruction like a foreign body, a malignancy, a bronchial stenosis, or something pressing from outside like a lymph node or a mass, which is delaying mucociliary clearance, causing post-obstructive retention of secretion and leading to a pneumonia which is not resolving. So just to give you another example, this is a 30-year-old male who came with fever and cough for 3 months. He was having these symptoms persistently, and he had this shadow, which is shadow seen just next to the right heart border. It's not silhouetting the right heart border, so it's more posteriorly situated, but there's a non-homogeneous opacity seen in the right heart border. The CT of this patient showed these sort of linear strands suggesting some degree of collapse with early bronchiectasis. And a bronchoscopy was done, and what we actually found was that the cap of a pen was actually lying in the lower lobe bronchus, and there was a foreign body which was present, which was actually causing the non-resolving pneumonia. So sometimes you need to keep these things in mind also when you look at cases of non-resolving pneumonia. The other issue is host factors. Local causes is sequestration. Abscess needs treatment within its own right. An empyema which has happened because of a parapneumonic diffusion getting complicated needs treatment within its own right. And even if you have purulent sinusitis, that can also delay the resolution of a pneumonia. Then you have congenital abnormalities like sequestration, cyst, and bullae, which also you need to keep in mind because they need treatment more aggressively, and that sometimes that also delays the resolution. So this is a patient who had come to us again with non-resolving pneumonia and had this dense shadows with some degree of mucus plugging and bronchiectasis, and he had history of expectoration also. But then if you look at the other scan, you would see that he has an aberrant vessel which is coming from the abdominal aorta going up into the lungs, which is basically because this patient has sequestration and he has an abnormal supply of this part of the lung from the abdominal aorta. So this was a patient of sequestration who had a non-resolving pneumonia. Another case, a 17-year-old male, he presented with fever going off and on for 1 year, cough with mucopurulent expectoration, he had dyspnea on exertion, and there was right-sided chest pain. He had received multiple courses of antibiotics, started on ATT. He had been on ATT for 6 months and actually was referred to us with a diagnosis of possibly MDR tuberculosis. This was the X-ray of this, CT of this patient, and you can see there's an air fluid level, there's a large opacity. This subsequently is a lower cut, which again shows a large air fluid level with a lot of necrotic sort of material inside it. So this patient was diagnosed to have tuberculosis despite the fact that sputum was negative, but his quantiferon gold was positive. Now quantiferon gold can tell you only about latent tuberculosis. Its utility in active tuberculosis is actually not there at all. And if you had such a large lesion, his sputum should have been positive. his bacillary load would have been very high. So we stopped his ATT, we did a bronchoscopy and grew Klebsiella. We started him on parenteral antibiotics, which we gave for 4 to 6 weeks, did good chest physiotherapy. He improved and we made a diagnosis of infected cyst. This is the subsequent CT of this patient, which showed total resolution of that air fluid level, which looked like a non-resolving pneumonia. This is a subsequent CT, the section which shows this large cyst which was getting infected, and that is what this patient needed, a more aggressive treatment. Then you need to keep in mind systemic causes, and this is something we've discussed in the previous session also. A pneumonia may not resolve if you have poorly treated diabetes, if there's underlying CKD, heart failure, HIV, or even patients who have other neurological problems. Then you have immunodeficient states which one needs to keep in mind. If you have B-cell defect, ALL, Streptococcus pneumoniae, and Haemophilus influenza are common causes. If you have a myeloma patient, think of gram-negative infection and treat aggressively. Similarly, if you have a T-cell defect like Hodgkin's disease, patient on steroids or cancer, tuberculosis, pneumocystis, and cryptococcal infection are something that you need to keep in mind. And if there's a granulocyte defect like AML, myeloproliferative disorders, staph, gram-negative pathogen, and fungal infections, aspergillosis, another thing that one needs to keep in mind. Then you need to keep in mind non-infectious causes. Remember, all that looks like a pneumonia could be a non-infectious cause. You could have vasculitis, granulosis with polyangiitis, diffuse alveolar hemorrhage, cryptogenic organizing pneumonia, eosinophilic pneumonia, AIP. All of these can actually look like a pneumonia and very often get treated as a pneumonia. And even neoplastic, even if you have adenocarcinoma, lipidic form of adenocarcinoma can look, the bronchoalveolar form of adenocarcinoma can look like a consolidation. And patients with heart failure can present with dyspnea and bilateral parahilar shadows, which will also mimic a pneumonia. So in literature, up to 20% of non-resolving pneumonia are actually non-infectious. So keep that in mind, that if you have a non-resolving pneumonia, make sure that you're not missing out on something that could be non-infectious, and that is something that you need to keep in mind. So I'll just give you another case. This is a 20-year-old lady. She presented with high-grade fever for 2 months, cough with expectoration and hemoptysis. She had history of blocked nose and epistaxis, and she was diagnosed with pneumonia, treated with injectable antibiotics, did not respond, referred with a diagnosis of pulmonary tuberculosis, and actually was on anti-tubercular treatment. When we saw her, she had fever, hemoptysis, and she had worsening of her dyspnea. She was having this X-ray which showed this consolidation on the right side, and there was some suspicion of cavitation on the left lung, where you can see this cavity which was present. Based on this, she was actually started on treatment for tuberculosis. This is the CT of the same patient, and you can see these large cavities which are present, showing like necrosis. There's also a nodule here with ground glassing which is present around it. This is subsequent cuts of the CT which again show these large cavities and a lot of ground glassing. Another cut of the same patient showing a large cavity with necrosis. This patient had cavitating lung disease, upper airway involvement, and we thought this patient possibly had granulomatosis with polyangiitis. Wegener's disease was considered. We evaluated her. Sputum AFB was repeatedly negative. C-ANCA was positive, but her urine examination also showed protein plus, and RBCs were positive. So again, if you have a non-resolving pneumonia, think of looking outside the lung also, because sometimes that may give you a clue to the diagnosis. Kidney biopsy showed focal proliferative glomerulonephritis, and we started this patient on treatment with steroids and MMF. Subsequently, this patient was put on maintenance rituximab. At the beginning, when this patient had come to us, we did not have that much of experience, but now she is on regular rituximab. Her hemoptysis has settled, dyspnea has improved, and there is radiological clearance at 6 months. This patient did not have the classical pneumonia. It was a non-infective cause, and multi-system involvement and radiological picture actually provided a clue to the diagnosis. This is her X-ray on follow-up. You can see the significant resolution as far as those cavities are concerned, and the consolidation of the right side is resolved. And this is the CT scan, and on 1 year, she showed significant resolution as far as the lung was concerned, showing that if you make the correct diagnosis and treat these patients, you can have a good response. This is another patient who came to us with fever and cough for 4 weeks, diagnosed as pneumonia and had a right lower zone opacity. He has a non-homogeneous opacity on the right lower zone, a little bit of shadow on the left side also. He was given parenteral antibiotics and advised ATT. As a matter of fact, his father-in-law was a doctor who kept ringing me up and telling me, why don't you start this patient on TB drugs. His sputum was repeatedly negative. We did a CT scan because this shadow seemed to have sort of some degree of cavitation, and that is why it was felt that this could be tuberculosis. The CT of this showed the classical reverse halo sign. You can see these shadows here, but you can see that the center part does not show necrosis. The lung parenchyma is preserved. This patient had classical organizing pneumonia. This is cryptogenic organizing pneumonia. Treated this patient with steroids, and he's done dramatically well. These shadows have totally disappeared. So the important thing is to remember that all those shadows that you see on the X-ray, which look like pneumonia and present with symptoms of pneumonia, may not classically be what we call infective pneumonia. So when you evaluate a patient with non-resolving pneumonia, what are the main things that you do? One, I think, is most important is a careful history. Take a history of comorbidities, exposure, travel, and think of non-infectious causes. And then what you rely on are imaging studies, microbiology, and then histopathology, if that is helpful. Pitfalls are that non-invasive microbiological testing is limited, and sometimes it's difficult to obtain sputum in frail and immunocompromised patients. Laboratory tests that one would do is blood cultures, sputum tests, gram staining, AFB, CBNAT, KOH for fungal, look for Legionella, do the urine antigen test, pleural fluid examination, and sometimes remember shadows can be because of pulmonary embolism, small showers of pulmonary embolism. Therefore, do a D-dimer, and if you still suspect pulmonary embolism, look for do a Doppler for the leg veins, look for deep vein thrombosis. An autoimmune workup will also help, and you could also look at serum ACE levels if you're suspecting consolidation, if you're suspecting sarcoidosis. CT scan, of course, plays a very important role because it helps you. It tells you the parenchymal abnormality, and I've just shown you some cases. It tells you whether there's mediastinal involvement or not, and if there is sequestration foci of infection like an empyema or a lung abscess, and it narrows the differential diagnosis or suggests new possibilities. So you could have ground glass shadows like this that you see on a CT scan, suggesting invasive pulmonary aspergillosis. Diabetic patient with chronic cough, low-grade fever, you could have a cavity like this, which is basically because of pulmonary tuberculosis. Or you could have neoplastic causes, some of them because of an endobronchial cause, which is causing stenosis, post-obstructive pneumonia. That is something you need to keep in mind. Sometimes you can have a cavitating malignancy, and that can happen in squamous cell carcinoma. And then you can have alveolar infiltration, both in lymphoma and bronchoalveolar carcinoma, which can also mimic a consolidation. And then vasculitis, I've already shown you a case. This vasculitis can present with these nodular shadows of cavities, and this is something that you need to keep in mind. And bronchoscopy, a transbronchial lung biopsy, workup for vasculitis, all can help you in making a diagnosis. So how would you approach a patient who comes to you with non-resolving pneumonia? I think if you have a patient, the first thing is to assess risk factors, look for comorbidity, severity of illness, and specific pathogens. Then see if you can get a history as far as our clues are concerned for unusual pathogen or for a non-infectious cause. And based on that, decide on investigation. More importantly, a CT scan. If the CT scan and your investigations give you a cause, then you treat accordingly. If that cause is not there, then you look whether if there's a parenchymal lesion, then a bronchoscopy, a BAL, transbronchial lung biopsy, or a CT-guided biopsy is something that you should consider. If they're associated mediastinal lymph nodes, you could consider an EBUS or a TBNA and treat accordingly. If everything is negative, you could even consider a surgical lung biopsy. Sometime before this, we would even do a PET scan to give us an idea of if there's something outside the lung which we could biopsy and get an idea of. So how would you approach these patients? One is keeping in mind that your diagnosis may not be correct. So you may have an incorrect diagnosis. So you're looking at other conditions, congestive heart failure, embolism, neoplasm, sarcoid, drug reaction, and hemorrhage. Then if you have a correct diagnosis, then you're looking at host factors, which may be causing the pneumonia to be non-resolving. Local factors could be obstruction, foreign body, inadequate host response because of immunocompromised state, or complications like an empyema or a lung abscess, which causes the pneumonia to become more severe and non-resolving. It could be drug-related, errors in drug selection. You're not giving the right dose, you're not treating the right bacteria or the right organism, or they could be associated with adverse drug reaction. And like I said, you could have drug-resistant pathogens or other pathogens. So if you have a person who's not responding, if the response is delayed, think of all of these causes in the early part, that is up in less than 72 hours uncovered pathogens, parapneumonic effusion, nosocomial pneumonia, extrapulmonary causes, or non-infectious causes. If you have a person who comes with deterioration, the shadow is actually worsening, then look at, are you treating resistant pathogens? Is it inappropriate treatment? Are you looking at empyema or parapneumonic effusion, or is it an incorrect diagnosis? If the patient comes late, then you're looking at nosocomial pneumonia or a superadded infection, exacerbation of comorbid condition, pulmonary embolism, or an extrapulmonary cause which is leading to this. So what I would say in conclusion is that non-resolving pneumonia is a common clinical entity. Host factors may delay resolution of pneumonia, including alcoholism, older age, and comorbidities. Keep that in mind. Sequestered foci infection like empyema, lung abscess may prevent adequate concentration of antibiotics, and therefore it may take a longer time to resolve. The presence of resistant pathogen is an important consideration. Also keep in mind alternate pathogens like tuberculosis, fungal infection, nocardia, and they need to be also kept in mind, especially in a person who has comorbidities for a non-resolving pneumonia. Also keep non-infectious causes in mind. I've shown you some cases because they can mimic pneumonia and therefore present as non-resolving pneumonia. Evaluation of patient with an apparent non-resolving pneumonia includes careful history, laboratory test, imaging, and obtaining materials for microbiology and pathological analysis. Thank you very much. Any role of physiotherapy? So I've shown one case. Physiotherapy, especially postural drainage, definitely has a role if in a case of lung abscess or a patient who has an infected cyst. Sometimes if you do that aggressively with good postural positioning of the patient, you will have much better resolution as far as infection is concerned, along with the cover of antibiotics.
That is gravity. But diaphragm movement by abdominal respiration, I think that will help in lower lobe pneumonia.
So atelectasis can happen, and that can also lead to delayed resolution. So yes, good diaphragmatic function will also help.
Dr. Guleria, for taking us through such a wide range of causes, etiologies which we may encounter in tackling this problem. If there are one or two questions from the audience, we can take.
I purposely did not. So there are.
Why have you not mentioned?
Yeah. So there is now the evolution which is based on two things. One is what we call point of care tests, and a lot of point of care tests are available which help in early diagnosis, which it could include diagnosis for Legionella, urinary Legionella, or even for COVID for that matter, influenza. And then you have a large number of array of tests which are available as far as the multiplex PCR is concerned. The pneumonia panel is also there. But they are more useful in getting a definite etiology. And if you are not getting a sputum sample or your sputum is inadequate, a pneumonia panel can be used. Cost is an issue as far as the BioFire and other tests are concerned.
The specificity and sensitivity of these BioFire tests?
So I don't think in community-acquired infection, I would really recommend that you should use BioFire unless you have a person who's not responding or an admitted patient. There is data which has looked at various panels, the pneumonia panel. Recently, there is a meta-analysis and a literature review which has looked at LRTI, low respiratory tract infections, and the utility of BioFire, showing a high specificity and sensitivity in a given context. So you have to look at it in a given context, because you have to understand BioFire will not differentiate between colonizer and invasive infection. You have to look at the colony forming unit, you have to look at whether there are enough neutrophils, and combine it with the clinical pictures. I didn't get that. So you're trying to say when you start empirical ATT, how do you handle medical legal problem? Dr. Tyagi is here to give us an idea of that. But I think if you discuss with the patient and explain to this patient that why you are starting antitubercular treatment, and that it's a therapeutic trial, and you note that down that this has been discussed with the patient, that you're giving a therapeutic trial, it is something that you can do. We sometimes have this problem when we have to take a call of sarcoidosis versus tuberculosis in patients with mediastinal lymph nodes. You do a EBUS, your EBUS shows a granuloma. Granuloma can happen both in tuberculosis, it can happen in sarcoidosis. And the patient's MON2 is positive, but your gene expert is negative. Then what do you do? So you have to discuss this with your patients.
Still, there is a role of any therapeutic trial. With this much of advent of all these tests and PCR and...
So I won't say that there is no role of therapeutic trial of anti-tubercular treatment, but the role has become much less. But yes, there is still a role of, in our country, tuberculosis is a great mimicker, and you may still have patients who, you may not pick up TB at all, but a trial of ATT may actually show response as far as fever is concerned.
So I have one question, one very specific question. That the patient is AFB negative, and it's a slow resolving pneumonia, the symptoms are resolving, but now the sputum has turned weak positive for gene expert. So how do you deal with it?
So this is a big problem that one has, because gene expert is very sensitive, and you may argue that it may be just a contamination that has happened. You again, like I said, have to discuss with the patient. Sometimes you will have to give the benefit of the doubt to the patient and maybe start ATT. Often you would also like to observe and see whether the patient is responding. But keep in mind that still could be tuberculosis, and be careful about the drugs that the patient has taken. If the patient has been on a fluoroquinolone in the past, then it may cause suppression, and your gene expert may later on become positive, because fluoroquinolone will suppress the mycobacteria, and you may have a delay in your diagnosis by 4 to 6 weeks because of fluoroquinolone, which has been given even if it's only for 5 days.
All right. Thank you so much for enlightening us, sir. Thank you.
Thank you.
Thank you very much, sir.
I request the chairpersons and speaker to kindly proceed to the felicitation desk. I request Dr. Mukesh Mehra to felicitate the chairpersons and speakers. Okay, before we proceed to the next session, we want to declare the results of the PG quiz and PG poster presentation. I request Dr. Pankajnan Chaudhary, Chairman PG Program, Dr. Rajiv Bansal, Chairman Scientific Committee, Dr. RPS Makkad, Organizing Chairman, Dr. Harshita Tyage, Organizing Co-Chair, and Dr. Paras Gangwal, President EDPA, to kindly come to the dais. Dr. Paras also to kindly join us. Dr. Paras and Dr. Makkad. First prize is for Team LHMC. I request Team LHMC to kindly come onto the stage. Second is Team UCMS. Team leader is Dr. Usha. And the other members are Dr. Himanshi, Dr. Prashanta, and Dr. Prabhakar. I request Dr. Rangdeep Guliare to kindly join us for presenting the trophies to the PGs. Okay, sorry. Next is Team UCMS, second prize. Team leader is Dr. Norman. The other members are Dr. Shilpi Srivastav, Dr. Tarun and Dr. Anamika. I request Dr. Rajesh Chawla to kindly present the trophy to the PGs. Rajesh Chawla, sir. Next is Team AIMS, New Delhi. Dr. Tariq is the team leader, I suppose. I request Dr. Sandeep Buddhiraja to kindly come over to the stage to present the trophy to the PGs. This team was a particularly last-minute entry. I think they were destined for this. Next are the e-poster results. First prize is Dr. Shubham Bansal from RML Hospital. Second is Dr. Aditya Agarwal from LHMC. Dr. Shubham, please come on. Dr. Aditya Agarwal from LHMC. And third prize is a tie between two, Dr. Kiran Babu from Yashoda Hospital and Dr. Shilpi Srivastav from UCMS. Congratulations to all the postgraduates. Dr. Kiran and Dr. Shilpi. We have another important announcement to make after this. I request Dr. Rajiv Bansal to kindly do the needful.
Good evening, good afternoon, everyone. And as the chairman of the scientific committee, I have an immense pleasure to announce that our annual EDPA conference will be held on 10th of December this year in Lee Meridian Hotel. And I invite all of you, and you can all, come over there, and we will try to have 2 days program this year, and you can enjoy the scientific bonanza this year. So all are invited. Thank you.
We are happy to announce the name of Conference Chair Pankaj Nan Chaudhary as organizing chairman and co-chair Dr. Ashok. Congratulations, Pankaj.
Thank you, Dr. Paras, and thank you, EDPA, for giving this opportunity. I see many faces, senior faces, Dr. Vijay Arora sir, Dr. Ashok Grover sir, Dr. Nakra, Dr. Chawla, Dr. Bhalla. So we are actually grown as a family of EDPA, and it's almost 22 years journey that we are doing this major conferences, and it will be the 23rd conference. So I'm very happy to have this, and definitely you will have the extravaganza of on 10th of December. I invite you all, and the first information brochure would be released soon. Thank you very much.
Now we'll proceed with our next session. I request Dr. Suchitra Jain to join us on the stage and start the proceedings of the next session. Who won in the poster and quiz competition to collect their certificates from the counter.
Good afternoon, all. Good evening, all. And I thank EDPA for such a great honor to moderate this session, a pertinent session of the conference itself, that is antimicrobial stewardship. For this, we all know the bugs, they are everywhere. Superbugs, we call them, because they race much ahead than what we do. And we all know that what we are struggling today is the antimicrobial resistance. We are struggling with MRSA, VRE, we are also struggling with CROs, MDROs. And for that, we all know that more than 1 million cases now are attributed to the infectious death. And that is why we have gathered today to find some solutions in the form of antimicrobial stewardship program. So for this, I would like to invite our very esteemed guest and esteemed chairperson, Dr. Ranjana Chhabra ma'am, on the stage. She is head of microbiology lab at Max Hospital, Patparganj, also heading infection control program. Next, I invite chairperson, Dr. Rajiv Bansal, on the stage to be the chairperson here. He's a very eminent, no introduction is needed for him. Please be seated. Now I invite our esteemed panelists, all very good in their field. And first of all, I would like to invite Dr. Sandeep Budiraja, who is Group Medical Director, Max Hospital. A round of applause for everybody, please. Next, I invite Dr. Lata Kapoor, who is an Additional Director, NCDC, New Delhi. I invite Dr. Sonal Saxena, Professor and Head of the Department, Microbiology from MC. A big round of applause. And not the least, now I invite Dr. Jatin Ahuja, who is a Consultant, Infectious Disease, Apollo Hospital. So with this in mind, that we all are struggling with antimicrobial resistance and what plans we should be having, what is it? We all know that in 2050, even some of the papers are saying that we will surpass the deaths which are now pertaining to oncology or oncodeaths, cancer death. So with this mind, what are the things which we should be looking at? So my first question will be to Dr. Sandeep Budiraja, that what are some of the practical considerations for selecting antibiotics when faced with infection? And what is that which is antimicrobial stewardship we have been talking about in the today's morning, sir?
So I'll start with the second part of the question first. So antimicrobial stewardship is a coordinated set of activities which ultimately aims at leading to a responsible use of antimicrobial agents. And when we talk about AMS program, it is not only limited to an individual or an organization. It is at a national, rather it is at a global level. And similarly, it cuts across, it's not only restricted for human beings, it's for animals, for the environment. So I think collectively, if we look at it, that's really the whole concept of an AMS program. Now, as a physician, how would I approach starting an antibiotic or deciding which antibiotic to use in a patient who comes to me with a fever? I think the golden principles of a basic clinical encounter, we must not forget. So a good history. After I've done a good history and physical examination, I make a clinical differential diagnosis. At the same time, I also need to make a microbiological or pathological differential diagnosis as to, in this individual patient, with the symptomatology he has come with, what are the possible microbiological, whether it's bacterial, viral, fungal, and if it is bacterial, what type of bacteria. Now, again, so there's a mnemonic called PEST, P-E-S-T. So P stands for pathology, where I just spoke about you have to understand the microbiological differential diagnosis. E is the epidemiology. Once you have shortlisted that probably it is these 3-4 bacterial agents which are causing it, what is the local resistance profile in the area you work in the region you work in, or in the hospital you work in? S is the severity, where we look into the host factors. Okay, so you have to understand the age of the patient, the underlying comorbidities of the patient. Is it the first time a person has come to a hospital with a symptom of fever, or has the patient been a chronic patient of a hospital, having previous hospitalizations, previous ICU stays, and when or what was the last antibiotics he took. This will have a huge bearing on my decision to decide which antibiotic. At the same time, now, if I have shortlisted that, look, these are the 5-6 antibiotics which could work potentially in this patient with this sort of infection, I have to then come down to the thing called the choosing the most appropriate of these 4-5 shortlisted antibiotics. Then I'll base my decision on the basis of efficacy, the resistance patterns as we just spoke about, the most narrow spectrum of antibiotic in terms of the clinical differential diagnosis which I have made, and the cost. And ultimately, the narrow spectrum and the cost might be the decision-making factor if the efficacy for all those 4 or 5 different antimicrobial agents is the same. And the last is the treatment, where, as I just said, after you have shortlisted the antibiotics, you'll then like to look for any organ involvement, the right dosing, and the right administration. So in a patient who has CKD or a liver disease or a heart failure, do I need to modify the doses? And depending upon then the PK/PD of that antibiotic, I will choose the route. And normally in a patient in outpatient setting, we like to use oral routes, and in patient in hospitalization, preferably an intravenous route. But many times the bioavailability of oral medications may be very high, and then I can choose. And the last step is to decide the duration of antibiotic, and then at the end of the day, coming down on my antibiotic choice or limiting the antibiotic depending upon the sensitivity as per the initial laboratory test which would have been done. So it is absolutely important that we send cultures prior to starting the antibiotic in the first encounter itself. And then timely de-escalation of antibiotics, and the duration of antibiotics. In fact, the conventional thought that 7 days, 10 days, 14 days may be irrelevant, and we can limit a shorter duration of antibiotic course to up to optimal of 5 days or so, depending upon what scenario we are looking for. So these are basic principles in which how I would choose, start, and monitor my antibiotic usage.
Great, sir. And just to put in some points, he's asking about the judicious use of antibiotics. He's also asking about the right dosage with the right timing. He's also asking to do escalation and de-escalation and restriction of antibiotics. That is what an antimicrobial stewardship, sir, is talking about. Right. Coming to the second question to Dr. Jatin, that is outpatient parental antibiotic therapy. How practical is this strategy to treat infections, and when to consider, in what circumstances is it justification? If we especially refer to our diarrhea and upper respiratory tract infection in OPD settings we are talking.
So as you mentioned, ma'am, it's an OPAT, it's an outpatient antimicrobial parental therapy. So when we are talking about the parental therapy, we need to look at the multiple factors before we start the OPAT therapy, ma'am. First of all, we need to look at the patient, what kind of disease patient is having it, whether the patient is having the chronic infection, whether the IVSS is there or not, whether the patient is willing to take the IV antimicrobial at home or not, whether the patient has the access to a trained nursing staff at home, and whether the right antibiotic is required in the form of IV at home or not. If there is a form of a de-escalation in the form of oral therapy, it should be done. If not, then all these factors coming into play, the OPAT role comes into the factor. One thing. Second thing, now you're asking about the patient who is coming with the diarrhea and may or may not be fever, and with the leukocytosis. So most of the patients who have the diarrhea, they are mostly viral in origin. Sometimes those who are already on antibiotic, or they have received antibiotic in the last few months, it could be a C. diff-induced diarrhea or antibiotic-associated diarrhea. Mostly the viral-induced and the toxin-induced diarrhea, they don't produce the leukocytosis. So if the patient is having leukocytosis plus minus the fever, the chances of the infective diarrhea or invasive diarrhea becomes high likely. So we'd like to start with those antibiotic which can be covering up the either Shigella or plus minus the Campylobacter, because they are all foodborne or I would say waterborne pathogens which can be targeted by the outpatient. If not, then if patient is sick or patient requires the dehydrated, patient requires admission, then based on the IV beta-lactam to be started.
Thank you, sir. Dr. Jatin, I'll come back to you again with some questions. One more question for you is, it prudent to start carbapenems in a newly presented critical patient in sepsis versus so-called carbapenem sparing agents while awaiting the cultures?
So if the patient is coming to our ER and straight away if we don't know the history part, then it's a tough decision to whether to start with the cephalosporin group or directly to the carbapenem. But if we have a brief history that whether patient has received antibiotics in the last 90 days and what kind of antibiotics patient has received, whether the patient is already on the hemodialysis, have access to the hospitalization earlier in the last few months, then those are the ones should be directly switched to the carbapenem therapy. If the patient is purely treatment naive in the last 90 days, no prior comorbidity, coming for the first time, in those conditions, I think the cephalosporins, whether the third generation or fourth generation, make some sense.
Or beta-lactamase combination, sir?
Yeah, BLBLI can be again started with like cefoperazone sulbactam.
Thank you so much, Dr. Jatin. Now, we all know we have been listening about the diagnostic support throughout the lab cultures, the importance of microbiological cultures, the organisms, and I think in today's era, the clinicians, if not, they cannot do without diagnostic, and with that lab support, I would like to ask Dr. Sonal Saxena, the next question is, what is the role of diagnostic stewardship in a antimicrobial stewardship program as such?
Well, diagnostic stewardship, I feel, is one of the biggest pillars of antimicrobial stewardship, because as we microbiologists in our language like to talk about garbage in and garbage out, the GIGO therapy, because we can only report on what you sent us. If the blood culture sample is contaminated with skin flora, that is what is going to grow. And no matter how rapid or how automated your laboratory is, if there is a 10 to the power 6 growth of a normal flora, and there is 10 to the power 2 maybe the actual pathogen, definitely the flora is going to overcome that. So the first and foremost thing is, when we talk about, is that there should be some support for training on sample collection, correct transport procedures and storage procedures. Now this is one thing which gets often left out, and we've often realized in our hospital also that most of the interns which collect sample, they leave it at room temperature, they put it in fridge, they don't know which sample is going to be stored where. So especially where your laboratory is slightly away from the hospital, this becomes a very major bottleneck. So first and foremost, this correct sample collection, obviously, like we say, the right drug and the right dosage, I always like to say the right sample from the right patient, collected at the right time, in the right manner, and transported in the right way to the laboratory as much as possible. Now, one example that I always like to give in clinician forum is, you tell your patient suspected of UTI, give your early morning urine sample for culture tomorrow. Now, we all forget our morning may be at 9 o'clock when we come to the hospital. Her morning or his morning could be at 4 o'clock. And they've collected that sample at 4 o'clock. It comes to my lab at 9 o'clock. It is processed at 11 o'clock. Now, a sample where E. coli was in 10 to the power 3 has now grown to 10 to the power 6, and it becomes significant. Because we did not tell the patient that the sample has to be processed in the next 1 to 2 hours. So the instruction should have been, collect a sample just before you come to the hospital. ये sample आप 10 बजे तक ले आइएगा, हर हालत में. 1 घंटे पहले लीजिएगा. But in order to have a better collection, and we've all read in our textbooks that it should be an early morning collection, we are actually spoiling the sample. So this is one OPD intervention which is nothing to do but just a communication with the patient that we have to taken care of. The other thing is that when we move and become clinicians, whether physicians or surgeons or anybody, we forget that it takes 24 hours for any bacteria to grow. And the moment we send we get a culture, we start getting the report that please tell us what has grown. So whatever automation I have, it's going to take 24 hours for the culture. Just as it's the 9 months and 1 week incubation period for the child to be born, the minimum incubation period for a bacteria to grow is 24 hours. So please remember that, my sincere request. Then, yes, if your lab is automated, your identification would be there in about half an hour. But if it is not automated, then another 24 hours for your other things. And AST will further take 24 hours. And blood culture, it gets propounded by another 24 hours. So even when you have the best of automated labs, you cannot get a report before 36 to 48 hours. The third point is that certain laboratories give direct sensitivity testing. That should be viewed with a lot of caution, especially in the era of AMR, because many a times we do get very major errors when we do it. And the fourth support from the lab comes from the antibiogram. So please ask your microbiologist to give you, if not 6 monthly, an yearly antibiogram. At MAMC, we take it out as a newsletter and put it up on our website for everybody to make your own empirical therapy, so that you are guided by your own local data as to what your bugs are, what your sensitivity patterns are. Even now you can access our antibiogram at MAMC website at mamc.ac.in. Similarly, your institutions must be bringing out an antibiogram. So utilize that antibiogram to tell you what should be your antimicrobial empirical first line therapy. And don't go by international standards. In case you don't have, NCDC every year, which Lata ma'am will tell you, brings out its own antibiogram every year. So even that would work, but the best would be to have an institutional support.
Thank you, Dr. Sonal. So she's asking for local antibiograms, basically. So every hospital or every region-wise, the local antibiograms can be circulated so that you have most prevalent antimicrobials and most prevalent microorganism around to choose for the empirical therapy. And then you can base your antibiotic policy according to it. Along with it, I think some point-of-care testing also can be added for diagnostic stewardship. Along with BioFire, we have Dr. Shalom there, who was explaining about the sepsis and the other modalities of treatment which can be combined for diagnostic stewardship itself. Thank you, Dr. Sonal. I'll come again with few more questions to you. Now, next question is to Dr. Sandeep. Sir, what we should be looking at when we are talking about the interventions to limit antibiotics resistant without hindering our clinical practice or inhibiting any cost-effective treatment? Basically, I'm asking cost-effective treatment for antimicrobials.
So, I'm not going to answer this question as a clinician, but rather as an administrator. Right. We spoke about what AMS program is. So it's basically a coordinated team effort. All the stakeholders need to be involved and participative. So actually the change starts at a global level and comes down to the patient level. And there are interventions, simple interventions, which do not need any cost or do not need much of a cost. WHO, for example, way back in 2011, 10, maybe earlier than that, put a big focus on antimicrobial resistance. In fact, that was their theme for one of their the WHO days. And the idea was to get all the member states to align with the AMR activities. Coming down to national level, India has AMR policy, and all healthcare organizations, private, public, NGOs, are supposed to be following that document as in spirit and actually in concept. And there are certain very key components in that, and I'll try to talk about one or two of them. The OTC drugs. In India, any antibiotic is available and can be given by a pharmacist without any prescription. I think that is something which, as a country, we should stop allowing that to happen. Second is, the AMR program clearly mentions the do's and don'ts to be followed at a hospital level. And at a hospital level, what can we do? So hospitals should have an AMR committee, should have an infection prevention and control committee, should ensure that all healthcare professionals, nurses, doctors follow the hand hygiene, okay? We have a policy of something called as restricted antibiotics. So if you want to put a person on a high-end antibiotic or multiple antibiotics, it should be ratified by a team. And that is just to put a hindrance or for a doctor to think twice that do I really need to give this prescription of high-end antibiotics. Education and CME and activities like these spread the knowledge and increase the knowledge of people, updates the knowledge of what's the scenario of AMR. innovation at a national level and vaccination. There was a session on immunization. I think anything which we can prevent from happening is a better thing rather than treating it with a higher-end antibiotics. And a cost-effective usage of medications. Now, there's a lot been spoken about the generic medications in our country, and I think the world is adopting it, and we keep debating about it. It's time we go towards cost-effective medications as long as they are efficacious. So I think these are, and there could be many more such interventions, but here I've just tried to list out some important ones which will go a long way in reducing the AMR problem in the country and at a global level, and do not incur much of a cost.
Right, thank you, sir. And something about fixed dose combinations, sir.
Yeah, absolutely.
It's one of the very pertinent factor when we talk about the antimicrobial stewardship program. Thank you so much, Dr. Sandeep. Now, next question is to Dr. Lata first, because we have talked about the administrator part. I would like to come. What are the challenges and opportunities for implementation of AMS? And as a policymaker, what are the relevant goals for AMS first?
So I think a lot has already been spoken about antimicrobial stewardship, and I would like to share with you that, as was shared by my previous speaker, that at the World Health Assembly in 2015, the WHO passed this resolution that all member states should be developing their own national action plan in alignment with the global action plan. And India did launch its national action plan for AMR containment in the month of April in the year 2017. And the National Action Plan has 5 key pillars. The first one is improving awareness and education. Second is about strengthening lab capacity for AMR surveillance. Third one is about strengthening infection prevention and control. And the fourth one is about judicious use of antimicrobials. And the fifth is about research and innovation. So if you can see in the national level document, which is National Action Plan, we have judicious use of antimicrobials through antimicrobial stewardship as a very important pillar. And another thing that I want to share with you, over the last 5 years, while we have been implementing National Action Plan, so NCDC is the nodal agency for AMR under Ministry of Health. And while we have realized that we cannot go by, I think my previous speaker did share about antimicrobial use, over-the-counter availability of antimicrobials, which is the unique thing in countries in the Southeast Asia region. And so if you go to the West, you don't get antibiotics. I think you know it very well. You go to Europe, you don't get antibiotics. So there, European countries and the Americas can say that, antibiotic misuse in animals is the predominant cause of AMR. But we cannot say so in India. In India, we still believe it is the use in human beings which is the topmost risk factor for AMR emergence. And that's why stewardship in humans becomes very, very important. So now the ministry, what it is promoting is that we work sectorally instead of only focusing on intersectoral. So I will share with you that many times we have postgraduates who come to our institution in their final years, and when we ask them, what is the risk factor for AMR? The topmost risk factor, they say antibiotic use in animals. So we tell them that if you only focus on antibiotic use in animals, then who is going to regulate the antibiotic use in humans? So in India, our population is huge. We have over-the-counter availability of antibiotics. So in India, the unique situation is we have to very strongly work for stewardship. And at the national level, this point is understood very well after 5 years of implementation of National Action Plan. And at the national level, Ministry has developed a national committee, technical expert group for developing a national antimicrobial stewardship guideline. But we are very happy to see that many private institutions are already developing. But I would like to share quickly some of the opportunities and challenges. So I want to share with you one of my experience. So while one of our site support visits, I was in one of the institutions and I visited the ICU, and the intensivist who was in charge of the ICU, he said that in my 40-bedded ICU, only one patient is on the antibiotics. And he said, how I'm able to manage this ICU with such low antibiotic usages because I involve myself in all the IPC practices in the ICU. So he was the ICU in charge. He knew which SOP, which protocol, cleaning protocol. So he has been a part of, even to the extent he knew what is the SOP for cleaning of the slippers that are changed at the entry of the ICU. So I really felt that the confidence of using less antibiotics comes when the physician is sure that the gateway of infections in my ward is very, so if a surgeon is confident of the OT, he will not be using antibiotics for more than 24 hours once he has stitched up the patient. So that is one example that I would like to share with you. And so I feel that when I see AMR at the national level, we are not at a very good place, and we cannot take AMR very lightly. And if we continue to move ahead the way we are, and as has been predicted by 2030, 2050, we will be in a very tough time, especially countries like India, Southeast Asia region, and Africa. So some of the challenges that I see as in implementation of antimicrobial stewardship are that AMS should be a priority of healthcare management. And in the corporate sector, it is very tough. And because I see the initial packages which are to treat patients do have high-end antibiotics like Penems, and which is not good. So I think somewhere taking care of our practice, because finally allopathy, the pillar of allopathy is antibiotics. I think we should somewhere, motivate our managements of corporate hospitals to, move on to antibiotics which are in the access group. I'm sure you're aware of the AWARE group of classification of antibiotics by WHO. So the access group is what should be used most widely because it has the least potential for resistance. The opportunity I see is that we do have trained manpower. I see at least 1 or 2 clinicians in every hospital is trained on antimicrobial stewardship. And prioritizing antimicrobial stewardship as an essential part of meetings by multidisciplinary committees like hospital infection control committees, and implementation of formulary, and I think restriction. I don't know if you have tried antimicrobial stewardship practices in hospitals, how many clinicians really listen to you. Educating and making clinicians aware, making them realize that if we continue to use antibiotics like this, we will lose them. And I think my next question, which you're going to share with me later, I will share some parts later. And finally, the one point that I want to share, already we are running short of time, I want to share is, somebody spoke about multiplex PCR today. So let me share with you, when you do multiplex PCR on a respiratory sample or on a gut sample, I don't think it's a wise choice, because I hear many physicians ask us that if you find 2 or 3 viruses or you find 2 or 3 etiology, what do you do? Why will you not find in your gut or in your respiratory tract a few, DNA or RNA elements of viruses or bacteria? So I feel multiplex PCR should be used in samples which are coming from sterile sites. That's one guidance that I would like to, or advice that I would like to give. And the other thing is about, so Dr. Sonal shared about the antibiogram. So why you can't compare antibiogram of Maulana Azad and Max Hospital? Because the culturing practices are very different. Max Hospital will be sending culture of every patient with fever. So you can imagine that they will have a more fairer picture of the pathogens, but MAMC may be having culture referrals only of very severe patients. So there will be the resistance in those antibiogram will be on the higher side. So that's why it's very important to have local antibiogram based, because one understands the culturing practices of one's own hospitals, and then accordingly one can decide on the empirical therapy. Thank you.
Thank you, Dr. Lata. So very pertinent. But we have been talking about hospitals. Like, I would like to put this question to Dr. Jatin. What about the outpatient clinics? We have many clinicians who are sitting here. How to actually implement antimicrobial stewardship, where to take that fear out that patient might go and ask for antibiotics from another physician. He might think, no, okay, this doctor did not prescribe me antibiotics. Should I go to the other one? And I know. So how do you take antimicrobial stewardship in those OPDs and for small nursing home or say non-corporate hospitals?
So if you really ask about the AMSP to be implemented, it has to be started from the baseline grassroots level, that is at the clinic site. Because where the patient are coming from the first-hand experience, directly patient getting the fever or some sort of pneumonia, coming into the, with their own personal physician, so clinic touch. And in that particular site, if you directly start away with the higher antibiotics, like injectable carbapenem or with the BL-BLI combination, then definitely you are predisposing to the AMR. So those are the sites where the minimal, I would say, only beta-lactam should be restricted, not even the BL-BLI combination also, and try to find out whether the patient is having it's a viral infection or it's a true bacterial infection. So we have to make a sense what kind of infection patient is coming up with. So if it is a viral infection, the patient has to be asked that yes, don't require any antibiotic, and please take this paracetamol or other supportive therapy. If you have some symptoms again, please do come after 48 hours. Because otherwise patient wants what patient wants. Patient wants the early quick relief. So that can be given by the paracetamol or something other supportive therapy, not by giving the just higher antibiotics. That is how we can play a role of AMSP at the grassroots level. But if we start straight away giving the higher antibiotic, we are predisposing the patient, because by the time patient comes to us in the tertiary care hospital, we are not left with the using a polymyxin B or newer higher combination like I would say ceftazidime ibectam. So the more we use judicially in the lower setup, I would say in the clinic side or in the nursing home side, the more we have the advantage of using the higher antibiotic in the tertiary care, because by the time patient reaches tertiary care, already has received so much of antibiotics, and the bugs which we are isolating, it's all are higher MDR bugs.
Thank you, Dr. Jatin. So very briefly, if you can tell about Dr. Sonal about the surveillance part of the network for antimicrobial stewardship and AMR resistance you are tracking, very briefly. We are running short of time.
Thank you, Dr. Sujitra. Actually, I'm the coordinator for the antimicrobial resistance network for Delhi. This we started in 2019, and then we took a little hit by COVID, but then we came out. And from 2020, we have 24 sites, which include a combination of private and public laboratories under us. And these 24 sites submit their monthly antimicrobial resistance surveillance data, and we are in the process of bringing out the reports every year, which we share with the members right now. We do not put them up in the public domain, but we've taken out publication after removing the data to one set as a Delhi antibiogram. You can access it at IJMM, where we brought out our data for 2020, and we're in the process of putting final touches to 21-22 data as another publication. So, and all these 24 sites, Dr. Suchitra and Dr. Ranjana are also part of that network. This has helped all the hospitals to generate their own antibiogram, and this has also trained them as to how this data is collected and how it can be utilized by the clinicians at their own hospitals. So I think it's been useful.
So we always talk about that our surveillance is not good, and people do outside India, maybe Europe or Americans have much more surveillance. But we are also having sites where surveillance network is there, and we can access that site for having, if local antibiogram is not available to you, you can access that and have some idea regarding that. Is that true? And then coming to Dr. Lata, we have been talking about the AMS. So how the implementation as a policy maker?
Doctor, I think we are short of time.
Yeah. So just in brief, if you can do the implementation of.
Yeah, so I think a lot has already been shared on implementation. I would just like to share that you had that I can share the other part of it. So let me share with you that in the name of AMR, there's a lot of push at the national level by some of the NGOs that we should bring in antibiotics which have not yet completed clinical trials. And I really feel we should not allow that. But yes, if there are new antibiotics which have complete clinical trials and we know they are safe and effective, the challenge is that if we bring them in, how will you prevent the small clinics in small towns? If you look at linezolid, it's a reserve group, but you know how much it is being misused. It's a bacteriostatic drug, but you see how much it is being misused. So the challenge with the antimicrobial stewardship with new antibiotics, so there's a lot of discussion at the national level that the newer antibiotics should be used only in states or in facilities where they have strong antimicrobial stewardship in place. So I think the steps of antimicrobial stewardship and implementation were already shared by one of the speakers before me. I would not like to duplicate that. But this point about getting new antibiotics within the system, we should be sure that they would only be used, only be used for patients who are very sick. And you know, in our country, when we wanted to reserve beds for COVID, what happened? Even for people who were not very sick, the beds were reserved. So our country is very peculiar with very peculiar challenges. And we should really be careful when we bring in new antibiotics. Whatever you will say, they will be misused. And so one has to really think. So at the national level also, we are still thinking, but
Yeah.
the drugs have to come in only after all the trials are complete. And if you
That's
have to do a third trial there, phase 3, then the patient should be having, you should have informed consent of the patient.
So,
to do that.
now, last not but least, I would like to ask Chairman quickly summarize the key messages and take-home messages from the panel discussion, if they can.
Thank you very much. I think it was an excellent discussion, and we should have more such discussions in every conference. And the important point is that it's a collective responsibility from the doctor's side, from the patient side, from the pharmacist, from the microbiologist, from the nurse, hospital, everybody. And many key opinion leaders are here. Dr. Girish Tyagi is here. If we can stop the availability of antibiotics over the counter somehow, I think that will play a very big role, because like in other countries, antibiotics are not available over the counters, because by the time the patient comes to us, he's already consumed many antibiotics on his own. So that is one thing which we can really do and prevent antibiotic resistance.
Thank you, Dr. Rajiv. Dr. Rajna.
Good evening. One thing which I would like to say, all has been discussed very well by our panelists, but the main point in antibiotic stewardship starts from the infection control, which is the first step, as Dr. Lata said. Once we have the infection control, and if an infection occurs, we find out what is the source and what is the cause of that infection, control the spread of that infection. That would decrease the use of then after that we have to decide whether the antibiotic has to be given or not, whether it is a bacterial infection or viral infection, according to that. So the first step is of infection control. After that we go to the infection treatment.
Thank you so much, and the panelists for such a discussion. Yeah, there's a question. Yes.
Antimicrobial system is providing the reports, and only then it will be given. We all are taking responsibility of ourselves. It is not the question of patient is coming and fighting. मेरा patient ठीक नहीं हो रहा, एक और antibiotic add कर दिया. मेरा ये नहीं ठीक हो रहा, उसको बुखार भी आ रहा, one more antibiotic is added. So it's our responsibility along with the community and government level also.
Right, sir.
This
So
should
the
not be
key
available.
education
The way
point
saying
is
the Linergid is available so freely. It should
Right,
not
sir.
be. Which government is saying it is a third line drug.
So
some
that
responsibility
is
we
very
should take to
right.
the government
The
also.
patient education as well, the clinician education is very must. And to summarize, I would like to say a Gandhian rule, if can be followed, as commando control and discipline. That is what is required for antimicrobial stewardship. Along with the change behavior, we should be having for antimicrobial stewardship program. Thank you so much,
Thank you,
our
thank you.
panelists and chairperson.
Thank you, ma'am. I request all the panelists and chairpersons to kindly proceed to the felicitation desk. I request Dr. Prakash Gera to felicitate the panelists and chairpersons. Next, I would like to invite Dr. Gaurav Agarwal to start on with the session on medical ethics.
वो ब्रोशर देना एक बार. नहीं, I don't need it. Good evening. At the outset, thank you, office bearers of the East Delhi Physician Association, for this opportunity. So we have this, very outlined and pointed panel discussion on medical negligence versus medical accidents. So for this, I would like to invite Dr. Girish Tyagi, Secretary and Registrar, Delhi Medical Council, Dr. Anil Chaturvedi, Dr. R.M. Chhabda, and Dr. Rajiv Lochan, please.
My dear friends, medical law has been evolving just like medicine. You know, we here read judgments every other day on our WhatsApp mostly that so and so compensation has been granted against a doctor in favor of the patient. And these compensations have been increasing, at every opportunity. And a landmark change has happened in medical education. We always cry कि भी ये तो हमको पढ़ा ही नहीं हमने कभी, ये हमको कभी बताया नहीं गया. But this is a fallacy, at least for the past 5 years now, under the new NMC curriculum, which I think Dr. Girish Tyagi would agree, since 2018, medical law has become an integral part of the MBBS curriculum. Am I right, sir? So now we cannot say that we don't know this or we are not supposed to know this. Not only this, I'm a part of a medical college and we are teaching it to students for the past 5 years. Now even there are practical exercises based upon medical law which MBBS students have to undergo, and these things starts from the first day of MBBS. I'm sure you know that the first month of teaching in MBBS is not anatomy, biochemistry and physiology now. It is called as something called as a foundation course, where they start with medical ethics and partly medical law. And this continues. Can we have some silence, please? And this continues till the end of MBBS, till the end of final year of MBBS, right? So there has been a sea change in the medical curriculum of MBBS. So with this background, on medical negligence versus medical, see, जब भी कोई complication हो जाती है, the idea is कि patient को हम कैसे counsel करें कि this is a known complication or this is a medical accident. Many of the times there are medical accidents, but the idea of having this session is that if we can somehow counsel the patient that most of these things do happen and it is not in the control of doctors, it is not even the control of your own body, it just happens. Then at that point of time, the patient, if the patient is convinced enough, then we are less likely to face suits against us in a court of law. So I would probably start with Dr. Girish Tyagi. Sir, what is the difference between medical negligence and medical accident, very broadly? Because we've got, around 21 minutes now. We'll have to go pretty quickly. We are already behind schedule.
Medical negligence is, first of all, the three components are there. First is the duty, breach of duty, and then consequential damage. Duty, of course, when once a doctor-patient relationship has to be exist, then of course, if the patient is going in the OPD, the receipt has been made, or the patient is being admitted under the hospital or nursing home, that means there is a relationship between the doctor and the patient. That means the duty is there. Then of course, breach of that duty. Breach of that duty means the standard of care which has to be provided with due diligence. Then of course, that breach of that duty, if it is directly causing the damage, it should cause the damage directly, then it comes under the purview of the medical negligence. And then medical accidents are the unintended results or outcome which are even after the providing the standard of care, these happening occur, which are going to occur, then of course it comes under the category of medical accident. As regards that, how to, first and foremost is the informed consent. That is the.
We'll come to that in a moment, sir. Thank you, sir. So just to summarize, so yesterday I was hearing Dr. Girish Tyagi in a medico-legal seminar organized by the IMA East Delhi branch, very, very comprehensive, and whatever he said, just a summary of, what all he described in a lot of details. So all these three components, a doctor-patient relationship, a breach of that relationship in whatever way, and damage. So all these three components have to be there. If any of these three components is missing, it would not constitute a case of medical negligence. And as far as medical accidents are concerned, as he rightly pointed out, that anything that is unforeseen, there are a lot of gray area between medical negligence and medical accident. We have to understand this. And if we understand, there can be a lot of clarity, there can be black, there can be white, and less of gray. So a medical accident is something that is unforeseen, an unforeseen event. A complication is something that you foresee, For example, postpartum hemorrhage, that is infection. That is something that you expect, but an unforeseen event is something that you do not expect as such. So that brings me to the second question, Dr. R.M. Chabra. Sir, can you give some examples of medical negligence as well as medical accidents that we see in common day-to-day clinical practice?
Medical negligence example I will give. If you have to operate the left one and you have operated the right one, definitely negligence.
Wrong limb operation.
Yes, wrong limb operation. Second example, I give the mismatch. If you give the blood with a mismatch, then definitely it is a negligence. These are the example of the negligence. Medical error, sometimes you will have given the medicine, there may be reaction, allergic reaction. It is error, not the negligence. If you have tapping the ascites or all that, there is sometimes peritonitis. This is an error, not the negligence. If you give the injection, intramuscular injection, needle is in the muscle and it is broken, then it is an error. These are the few examples of the medical negligence in the error.
Thank you. Very beautifully put. So, how do we ultimately decide that what is a
Dr.
medical
Guru, just one word. If the patient is allergic to a drug and it has been told to you, and if it is still being prescribed, then it will come under the medical negligence.
Yeah, absolutely. Right. Yeah.
Not that all the reactions comes under the medical accident.
Absolutely.
It will come under the medical accident.
So courts have been, proactive in diagnosing sort of as to what all constitute medical negligence and what all does not constitute medical negligence. It would be wiser if we go through what is called as a Jacob Matthews judgment, and it is a very, very, landmark judgment in the sense that it not only defines the components of medical negligence, but also gives very comprehensively what are certain examples that the courts consider that agar wo ho gaya hai to res ipsa loquitur hai, that means the thing speaks for itself, it is medical negligence per se. So as Dr. Chabla rightly pointed out, mismatched blood transfusion, that is one. Second is, these are the words of the court, and anything that the court says becomes a law of the land because this is directly coming from the highest court, the Supreme Court of India. Burns caused from electric cautery. Gangrene developed in a patient's arm following an intramuscular injection. A doctor fails to diagnose a known complication of surgery on a patient's hand for example, Paget's disease. Delay in treatment of as much as 50, because these things have come from cases in the courts itself. And in a particular case, the court said that a delay of 50 minutes in obtaining expert obstetric assistance at the birth of twins when the medical evidence was that of the no more than 20 minutes should elapse between the birth of the first and the second twin. Following an operation under general anesthesia, patient in recovery ward sustained brain damage caused by hypoxia for a period of 4 to 5 minutes, for which there was no explanation by the doctor that what proper treatment was administered to the baby. A spinal anesthesia anesthetic became contaminated with disinfectant as a result of improper storage of the same. Explosion that occurred during course of administering an anesthetic compound. These are examples categorically stated by the Supreme Court of India as far as, medical accident is concerned, also called as therapeutic misadventure or a mishap or a medical disaster. Fatal allergic reaction. See, as Dr. Tyagi already clarified, that if you are continually administered despite a positive hypersensitivity reaction to a test dose, then it constitutes negligence. But if it is negative and you administer it and it still causes anaphylaxis or maybe death or damage to the patient, then it is not negligence, then it is an accident. It so many times happens, you give a test dose to penicillin, it is negative, but when you finally administer it, the patient dies, so this is a case of medical accident or a mishap. Then patient dying of shock due to a attempted pericardial or peritoneal tap. What is required is, at the point of law, that whether you used enough countermeasures to handle that emergency or not.
if you attempted to but did not have enough, equipment or material available at hand to handle that emergency, then it would become medical negligence and not an accident. A very common thing, keloid formation. It's not in the hands of the doctor or even the patient. So it is a medical accident, not a negligence. So that brings me to the next question. Dr. Chaturvedi, sir, how do you defend a case of medical negligence and a case of medical accident in short?
As we have already discussed, medical negligence, as we have said, there are 4 act of commission and act of omission. Very fundamental. What you have done, which you are not supposed to do. What you have not done, which you are supposed to do. So suppose there is a patient and you are supposed, as he has said earlier, there is simply there is a hemorrhage. How to quickly respond to the hemorrhage, switch, stitch the hemorrhage, and then, so this is, will not be covered in negligence. Where he has very clearly said they are defined the negligence situations where you have given a pethidine to a patient of bronchial asthma or morphine to a patient of bronchial asthma, wrong, operating on the wrong thing, not taking an informed consent of the patient and doing something different, not what you are taking. Whereas accident is unexpected. It is unexpected, not expected and sudden, without any warning. So these things do occur in, as the examples have already been said. So when you have taken a allergic test, allergy test, and given an injection and something untoward happens, that will be cause an accident. So these are very clear. Act of omission, act of commission. What you have supposed to do, you have not done, that will negligence. What you are not supposed to do, you have done, that will negligence. Basic, simple.
Thank you, sir. So anything, Dr. Tyagi, you would like to add, sir?
Sir, how to defend a case? Whenever the case, suppose a complaint is being filed against the doctor for that matter, first of all, just go through the records, because ultimately the records will decide your fate. Whatever it is documented in the records, that will decide the fate. Rest of all, कि कब केस आ रहा है, कोर्ट में जा रहा है, मेडिकल काउंसिल में जा रहा है, कहाँ पे जा रहा है, कब आएगा. But once the patient, there is a complication, there is some mishap in the hospital or the nursing home, and as a doctor, we are aware that something wrong has been taken place. Since it is only a doctor platform, we can discuss. We have at least, we have some time. Hello?
Yeah, you are audible.
Hello? Yeah, since complaint is being filed, that means whenever, if it is being to the police or court, etc., they will ask for the document. You have at least 72 hours to provide the document to that concerned statutory authority. So at least go through your records. कि वहाँ पर consent है कि नहीं है, record proper है कि नहीं है, if there is any disparity between the doctor's notes and the nurse's notes. But most of the time it is seen that there is a disparity between the doctor's notes and the nurse's notes. Doctors के notes में जो हमारा RMO लिख रहा है वो blood pressure normal जा रहा है, nurses के notes में suddenly patient is being shock में जा रहा है, और nurses, when we are going through the nurses notes में blood pressure का 70-60 दिखा रहा है इसका. That means कि there is a fault. So first of all, to protect ourselves, take care of your notes, take care of your then of course once the notes are proper, if the notes are proper, you are not going to be convicted. Of course, when the complaint is being filed, you will be asked by the different statutory authority for explanation, for maybe medical council or national medical commission, you will maybe asked to come and appear in person for a defense. But if your notes are proper, harassment can be there, but the conviction will be less.
Thank you, sir. So the idea is, see, whenever our job is to prepare defense for a client doctors in case of a complaint. So what happens is sometimes doctors take it very lightly कि ठीक है यार हमारी तो कोई गलती है नहीं तो हमें क्या डरना है. That is okay, fair enough. But how does law? See, whatever you are going to write on the piece of paper, starting with when you first saw the patient and started writing a prescription, okay, to the answer to a complaint by the patient. You know, it has to be very, very careful. See, every document that we prepare, whether electronically or goes under a handwriting, is a legal document. Okay, so it has got a lot of legal value. And whatever we write, whether we are writing in defense, that is to be put up to the medical council, you have to understand that tomorrow it is going to a court of law, whether consumer court or criminal court, or to the police, or to, you know, maybe government authorities or wherever. So it has to be very, very nicely drafted, and every statement that you write has to be based upon an evidence coming straight from your file case papers itself. For example, if there are three elements, you know, breach of duty, doctor-patient relationship, and then finally damage. So you have to defend all these three points under three different headings. कि there was either no doctor-patient relationship, कि patient मेरे पास आया ही नहीं, दूसरे के पास आया था, मैंने तो दूसरे डॉक्टर को अपनी ओपिनियन दी थी, एक्सपर्ट ओपिनियन, पेशेंट को डायरेक्टली कंसल्ट नहीं किया था, फॉर एग्जांपल, ओके, और द पेशेंट, आई नेवर सॉ द पेशेंट, यू नो, एंड और देन सेकंड पॉइंट ऑफ ब्रीच ऑफ ड्यूटी, ओके, कि जो डॉक्टर पेशेंट रिलेशनशिप ही डेवलप नहीं हुई, या और वॉट एवर आई डिड, इट वॉज नॉट ए ब्रीच, इट वॉज स्टैंडर्ड medical protocol of treating, of managing that particular medical condition. And lastly, damage. For example, अगर patient एक limb पे surgery हुई but दूसरा किया, if the other one was also diseased, then there was no damage to the patient because he required treatment for that. I'm just, you know, one of example. But if there was no okay, the patient, सबसे बड़ी complaint होती है कि पैसे दिए, for example, investigations कराई, but कोई result नहीं आया, ठीक नहीं हुआ मरीज, तो उसके लिए कंप्लेंट कर दी. नाउ कंप्लेंट तो आसानी है, बट डिफेंड करने में, यू नो, मैनी मंथ्स टू ईयर्स लग जाते हैं. तो पेशेंट को डैमेज तो अगर नहीं हुई है, देन इट इज नॉट ए केस ऑफ मेडिकल नेग्लिजेंस, then that complaint would not hold good. But then you have to nicely defend it, then the patient has not suffered any damage whatsoever, you know. And then coming to medical accident, as rightly pointed out, ki, you did not do anything that was supposed to be done. Then all due precautions were taken, and you had all the infrastructure and everything to give to manage that particular complication. There are certain cases or questions that have come up on discussion with our colleagues, so I'm taking them very quickly. You know, if you have any questions, you are most welcome to ask. Dr. Lochan sir, there is a question that has come up. It's a very common clinical scenario. When prescribing antibiotics to a patient with fever, how much do we need to substantiate clinical findings with those of laboratory findings such as blood cultures, CRP, procalcitonin, PCR, all these things? You know, things do not match. What do we do? How do we legally, how can we legally be safe?
See, theoretically and practically things are very different. Seeing an OPD patient and talking of antibiotic culture and calcitonin and all those tests doesn't hold good really. So when a patient first comes to the OPD, first 2 or 3 days, I believe we should not give any antibiotic, at least 2 days. Give just painkillers or antipyretics. After that, most of us what we do is, and so you will agree with that, instead of going for cultures, everything, we give an empirical antibiotic. But if a patient is having a high-grade fever, looks toxic, has got certain eczema, anything which is pointed towards being a serious problem, I think before giving any antibiotic, we should give a blood culture and only then start an antibiotic.
The question is, if the laboratory results do not match with clinical findings, how do we go ahead as far as legal, you know, safety is concerned?
That is very difficult. You see, a treating doctor and a pathologist never go hand in hand. Because a pathologist never faces the patient, he's not bothered what the tests are. I am facing the heat, I need results with me. But majority of times, the tests almost go, if the culture shows what is the antibiotic, you're giving the same antibiotic, even if the patient doesn't improve, it is not your fault.
Let's say Vidal is positive, but the clinical findings do not match. What do we do? Very common scenario.
Now, Vidal is very important. This is where experience comes. If a patient has a fever more than 15 to 20 days and Vidal is positive, be sure it is not enteric. You have to look at something else. In my practical experience, I've seen, so only on Vidal, we do not diagnose enteric. There are other tests, and the only specific
Tomorrow
test...
the patient can say कि विदाल तो positive था, but डॉक्टर साहब ने उसका treatment लिखा ही नहीं. तो how can we be legally safe? Dr. Chabra, would
This
like
is
to
very
add
difficult to
something?
do.
Sir, we have been taught you start the broad spectrum antibiotic and send the culture sample for the culture
Sir,
sensitivity.
we are talking about law. Medicine तो आप सभी ज्ञाता हैं.
That's why I asked the question to Dr. Randir Guleria.
So let me try to attempt to answer it.
Yeah.
See you write it on your prescription that the clinical findings do not match with the laboratory results. That is one. Secondly, you order for a repeat Vidal, maybe typhoid, whatever you clinically feel. The idea is that anything that is scientifically explainable is legally safe. Please mark my words. And when I say scientifically explainable, that means you have to be ready to back it up with solid references. What are those solid references? Number one, textbook references. We are not talking slightest of mishap, we jump to references from published articles. No, published textbooks first, that is number one. Uske baad, published Indian reference papers, published papers. Okay, then international journals, then lastly international journals published papers. In that order of preference, mind you, we say कि judges को क्या पता है law के medicine के बारे में, उनको तो कानून मालूम है. Judges are very sharp people. They know a lot of things about a lot of fields. They know about economy, they know about politics, they know about domestic violence, they know about medicine. You know how law works. It's a funny thing, but it's a very interesting thing. So whenever you are defending yourself, you should be ready to back up each and every statement, by a solid reference. And if you can back it up, you are legally safe. That is the point here. That is how you defend. So if findings do not match with results, then you write it, let the patient sign, and you are safe. That is the point here.
As you documented.
Please, very quickly.
I think Vidal is not the only, test to
That
be
was just one example.
information.
Yeah.
You can write your clinical findings. You can have an ultrasound also done, whether is splenomegaly is there or not, whether there is a pink sign, your tongue is coated and dry, what is the leukopenia or not. If you write all this and then start the treatment, I think you are quite safe.
That's right.
So that's
regarding their prescription, it should be a rational prescription, and there should, whatever you are writing, गलत है सही है, there should be some justification. कल को आपसे पूछे तो आपको you can justify whether it is state medical council or consumer court, why you have written. If you are able to justify that, nobody can take action against you.
Absolutely. So I can take only a couple of questions now, looking at the time at hand. So how much insurance, it is in the interest of everyone. How much insurance do you have? I'm talking about indemnity. Any random answers? How many lakhs, crores? Sorry? 1 CR. Anything else? Any other answer other than this? I know so many people are sitting quiet, so obviously they have something else to say in their mind, but I want to hear them. So, okay. Anything else? Yeah. I'm talking about compensation has been granted. So how much insurance cover, indemnity cover should you go for? Dr. Dr. Lochan, how much do you have, sir? 50 lakhs, you have 50 lakhs. How much you have, sir?
I see the insurance cover depends upon the type
How much
of...
do you have, sir?
1 CR.
1 CR. Sir, Dr. Chabra? Okay. So we suggest that, see, now courts are very, exuberant in granting compensation, and it is last month itself, there were 3 cases of 1 crore each. So if you are having indemnity insurance, anything less than that, you have, be ready to pay from your own pocket. So if you are a practicing physician only a single doctor clinic, at least anything less than 1 CR is not recommended. In a corporate setup, anything less than 2 CR is not acceptable. For a surgeon, whether in a private, your single clinic or in a corporate setup, anything less than 2 CR is not recommended at all. So if you have anything less, you should have enough funds to pay to your patient. Okay. So if there are any quick questions, we can take them up. Otherwise, we end the session. Yeah, please. Yes, ma'am. So there are many ways to handle this situation. One is you complain to the police that there is a quack who is practicing. If you have the guts to, take help of your association, let them write on their letterhead. Okay, you cannot do it as an individual. It would be always recommend to take help of association. Secondly, you can report to the medical council. They can take action. Dr. Girish Tyagi can take action in the state of Delhi, but obviously the UP Medical Council can take action, and that person could be caught and imprisoned. They go along with the team of police and catch those persons. Am I right, sir?
Yeah, Dr. Archita, if you have some document means कि अगर आपका prescription किसी का है, कोई आपका most of the time, okay, most of the time prescription नहीं दे रहा, अगर आपका patient जो आ रहा है, suppose a patient treated by a quack comes to you in a critical condition, at least at that time he might give you in writing that I was treated by such and such person, he was given some, तो वो आप document जो भी आपके पास है इस तरह का, you can submit to UP Medical, ideally to the UP Medical Council or your गाजियाबाद में जो UP का, or if you don't, you submit to Delhi Medical Council, we will send to UP Medical Council for at that time it will show that they will take action.
Because when they come to us, then they should immediately get well. And they have been taking for 15-16 days treatment at that quack, nothing they are staying against him. But as soon as they come to our hospital, immediately they want to be good in 24 hours and the fever or anything doesn't go down. अरे आपसे तो कुछ हुआ ही नहीं है.
So I think the question has been answered.
Madam, दूसरा तरीका है कि आप एक
Yeah, please, sir.
I think we can always write that patient was taking treatment for RMP for 15 days, not improved. Just one line.
Yeah, that may not be enough evidence because we will need some document to support that. Tomorrow the patient.
When we write the history in that, we can write.
Yes, but to have legal document, to start a legal process against that person, because that needs to be out of the society. We have to have some document. Yes, that would become a document. Yes, sir. Please.
Now at a clinical level, suppose a patient comes to me with acute pain, body ache or spasmodic pain, he is given injection and he develops severe anaphylaxis. And we can give only anti-allergic.
It is a medical accident. We've already covered that. You are safe if you have done everything. Yeah.
And by the time we refer him to the hospital,
he dies on the way.
He dies. So what will happen to the doctor who had given the injection?
It doesn't matter. See, till the time he was there with you, you did all that was required to save the patient's life. Okay? It is not our duty to transport the patient to the hospital. If they have taken it on their own will, it is their responsibility. The caregivers, the patient's caregivers' responsibility, not ours. There was some, doubtful wordings in the Clinical Establishment Act of 2010, but as I was hearing Dr. Arun Gupta, the president of Delhi Medical Council, and Dr. Girish Tyagi yesterday in East Delhi, so they have, for the state of Delhi, got this provision out that it would not be the responsibility of the treating physician to see that the patient has been healthily transported to the target hospital. Okay? So yes, there could be state differences, but as far as this thing is concerned, it is not. For a nursing home or hospital, if you are sending an ambulance, then it becomes their liability, without any doubt. Okay? Please. Yes, sir.
In the OPD, suppose a patient comes, and of course, if whatever the reason injection, because your prescription will be in the legal scrutiny. That should be the ideal prescription. Ideal prescription means कि वहाँ पर उसके patient की findings लिखी हों, injection आपने दिया गया because of such and such is a patient के. In one of the case, a patient, जो हमारे पास Delhi Medical Council, we got that a patient comes to at OPD. Patient becomes critical. He was in critical condition. What was mentioned in that report? Patient critical, referred to a government hospital. इन बिटवीन द पेशेंट राइट. अपोज जैसे आपका पेशेंट आया, उसकी डेथ हुई थी, रास्ते में हुई थी, हॉस्पिटल में थे, सपोज ये मेडिकल लीगल केस तो बन गया आपका. दैट मीन्स योर प्रिस्क्रिप्शन जो भी आपका, इट विल कम्स अंडर स्क्रूटनी. ऑफकोर्स चाहे वो मेडिकल काउंसिल में जाए, क्रिमिनल कोर्ट में जाए, और मेडिकल लीगल केस बनाया, दैट मीन्स इट विल गो टू द क्रिमिनल कोर्ट, बिकॉज अल्टीमेटली द पुलिस विल कम इनटू द एक्शन. सो योर प्रिस्क्रिप्शन शुड बी, जो आप मरीज को देख रहे हैं उसमें प्रिस्क्रिप्शन में आप पेशेंट के क्लिनिकल फाइंडिंग्स क्या हैं, क्या लेके आया वो, आपने इंजेक्शन दिया, इंजेक्शन का देयर शुड बी सम जस्टिफिकेशन का आप इंजेक्शन उसको देने की जरूरत थी, उसको दिया उसका. एंड ऑफ कोर्स बिकॉज इन दैट पर्टिकुलर केस पेशेंट एक्सपायर्ड हुआ, उसको अगर उस पर प्रिस्क्रिप्शन में लिखा है पेशेंट बिकम्स क्रिटिकल with no findings, no pulse, no blood pressure, no respiratory rate, no oxygen, SpO2, then of course action can be taken against the person who has given the injection. आपने बिल्कुल ठीक करा होगा, उसमें कोई बात ही नहीं कोई, but of course there will be harassment, आपको बुलाया जाएगा इधर उधर, आपको इस और आपका प्रिस्क्रिप्शन पे आपको क्या जवाब दोगे, because ultimately your 2 साल बाद आता है या 6 महीने बाद आता है, of course your memory will not remain that कि पेशेंट उस कंडीशन में था. सो प्रिस्क्रिप्शन पे उस टाइम आपको यू हैव टू बी वेरी केयरफुल व्हेन अ क्रिटिकल पेशेंट कम्स टू यू, और इफ नॉट क्रिटिकल इवन अ नॉर्मल पेशेंट, बिकॉज द प्रिस्क्रिप्शन is in the hand of that particular patient, and patient को can show that to prescription to if it is not being cured to some other doctors. And most of the time, at least one statement I am using, that most of the complaints are being filed against the doctor because of her own colleagues. क्योंकि आपका प्रिस्क्रिप्शन लेके मेरे पास आ रहा है, मैं उसका अगर नहीं भी कह रहा कि हाँ जी प्रिस्क्रिप्शन का ऑर्डर, आई विल जस्ट थ्रो दैट प्रिस्क्रिप्शन, मैसेज इज बीइंग कन्वेड टू दैट पर्टिकुलर पेशेंट और द रिलेटिव दैट आपने क्या करा होगा. So we have to be very careful in that.
Thank you, sir. So just at the end, let me throw a question. Can you deliver a session over here, which has been sponsored by a pharma company? We are already doing this since morning, and we always do. Yes or no? Yes or no? No, not required. Not required. So the idea is that as an advisor or a consultant or a researcher,
you can,
or or a treating physician, for all these 4 capacities you can. See, we all do it, but always go with a legal contract between you and the company. You are 100% safe. For this conference, the association is taking whatever, the money. It is legal, but an individual doctor cannot. But if you have a legal contract, you can do it without any problem.
Dr. Gaurav,
so, Doctor,
जो अभी तक IMC regulation पे जो था, but in the National Medical Commission regulation 2022
next month जो आने वाला है,
जो proposed है, उसमें CME के लिए
परमिशन लेनी पड़ेगी.
Third party, you
that
cannot.
will be totally different scenario. Totally different scenario.
Of course, at Delhi Medical Council we have. We have stated our objection to the National Medical Commission as well as the state government that these conferences will be difficult to organize because the third party, that means
I'll
if I am
take your
attending.
leave with this. I thank Dr. Girish Tyagi, Dr. Chabra, Dr. Chaturvedi, and Dr. Rajiv Lochan. Thank you for a patient hearing. Thank you so much.
I request the panelists to kindly proceed to the felicitation desk. I request Dr. Makkar to felicitate the chairpersons and speakers. Now I request Dr. Anil Mota to kindly come on to the stage and start with the next session.
स्लाइड नहीं है इसमें. Okay, good afternoon and evening to all my friends and sitting over here. I know that's getting a bit late, but I'm sure that we'll do a good job. And the topic that we are basically going to talk about more or less and briefly is what the battering we got during COVID. That there was a heart failure and there was a COVID, and then there was a interplay of the two, and then we were suffering. And then we came to know later on that there is a big malignant connect between the two. Just a minute. So for this, especially heart failure and infection and coordination of the two, I have a wonderful, panel with me. So I would like to invite them. As speakers, we have Dr. Rajiv Rajput. Please come on stage, sir. Then Dr. Diman Kali. Please come on stage. We also have a wonderful bunch of panelists. One is Dr. Chand Watal. I'll introduce him shortly. Dr. Chand Watal, please. Then we have got Dr. Anand Pandey, Dr. Rajiv Pasi, and Dr. Amitabh Yadwanshi. Dr. Rajiv Rajput is a senior consultant in cardiology at the Indraprastha Apollo Hospital. I'm sure he's known to all of us. And he has a prolific experience in interventional cardiology. Dr. Diman Kahali is the director of interventional cardiology at the Birla Heart Research Center in Kolkata and the ex-chairman of National Institute of Cardiology at CSI. Then Dr. Chand Watal is the director, chairman of immunology and microbiology at the Sir Gangaram Hospital and a huge experience in microbiology and immunology. We have then Dr. Rajiv Pasi. Dr. Rajiv Pasi is the chairman, director of cardiology, interventional cardiology at Sir Gangaram Hospital. We have Dr. Anand Pandey. He's the chairman and director of interventional cardiology at Kailash Deepak Hospital. We have Dr. Amitabh Yadwanshi. He's again a senior consultant and director of cardiology at Holy Family Hospital. So with this galaxy of speakers, I want to, there'll be a brief 2 talks about heart failure, and then we discuss the interplay with the this infection. So we have to talk of heart failure. So heart failure, I'm just giving the definition, is a clinical syndrome. This is what is known as the universal definition of heart failure. And this presents with symptoms and signs which is caused by a structural and or functional cardiac abnormality and corroborated with elevated BNP levels or objective evidence of pulmonary or systemic congestion. This definition of heart failure has withstood all the tests of time. And then second is about infection sepsis. I think from the morning we have been listening to about infection sepsis. I will not go into that. So with that, I invite Dr. Rajiv Rajput to the stage, and he could be talking of quality of life, an important aspect of heart failure. Sir.
Good evening. Thank you, EDPA, for inviting me for this presentation on quality of life, an important aspect in management of heart failure. Whenever we talk about chronic debilitating illness, there is always a very important concept of quality of life. But traditionally, all the trials, what they aim for, lower mortality, lower morbidity in context of heart failure, better hospitalization, and we also look for agents which improve heart functions and relieve symptoms. But quality of life is a very, very important concept, and I'll explain why. Quality of life reflects the way a person's mental and physical well-being is evident in their everyday life. Because besides health, many other things can also affect quality of life. So the correct term would be health-related quality of life. And it affects because of either effect of illness or because of the treatment. Traditionally, as a cardiologist, as a physician, we are more important in physical aspect, like blood pressure, like pulse, like chest crepitations. Chest is clear, blood pressure is okay, everything. But it is not patient's only concern. He is worried about change in his symptoms, his physical function, and his broad social sort of role he can play and he would like to play. This is a busy slide, but just read one by one. Because of physical symptoms, psychological problems, or adverse effects of the treatment, patient withdraws from the activities he was used to. He loses his social contact and social support. Point 1. Disturbance and rift because of the various reasons caused by the family members struggling to meet illness-related demands, and inability of family and friends to cope up with the deteriorating health leads to withdrawal of the contact from the index patient. The increasing severity of the disease leads to individual being aware of his own situation, precarious situation. He may not survive, he may not be able to do the things he wants to do, and that leads to depression, sleep disturbance, and anxiety. Personal relationships, eating, sexual activity, and inability to work, they are all limited, and they are associated with increased dependence on others. Quality of life is an opinion found by persons' interpretation of their own health status in comparison to what they might hope to be able to achieve. So this sounds a little philosophical, but from patient's point of view, it is the most important thing. Somebody comes to your clinic, you have prescribed him guideline-directed medical therapy. He is not dyspneic, he is not much dyspneic, he is sleeping, he is eating relatively better, but he is not able to do a number of things he wants to do. So to you, he might appear okay, but for him, he has a poor quality of life. So how to interpret this? How to assess it? Are there some objective or semi-objective ways to quantify the quality of life? Yes, there are. And various scoring systems have been divided. Quality of life in severe heart failure questionnaire, chronic CHF questionnaire, and the most talked about is Kansas City cardiomyopathy questionnaire, KCCQ, left ventricular dysfunction questionnaire, and Minnesota living with heart failure. These are simple questions which are addressed to the patient about their daily social, physical, mental activities, and finding out how much they can do and grading them. So why improving quality of life is important and why it should be the key parameters? Because first of all, quality of life, which is whatever score you measure, say in this study, Alberta Heart Study, KCCQ score which we talked about, in 1/3 patients, it almost always deteriorates in a year's time. So quality of life generally in most of the heart failure patients with time deteriorates. How does it matter? What is the relevance? Relevance is this, that if you have 4 group of patients, one with the good quality of life and one with the worst quality of life, you can see from these charts, those with good quality KCCQ score have better prognosis in terms of all-cause mortality as far as hospitalization. Now, whenever we have whatever score we follow, there are certain values which we have derived, like KCCQ score. Now, whatever your score is, if your patient's score goes up by 5 points, that means he has significantly improved. If it goes down by 5 points, that means he has significantly deteriorated. So if you have a patient whose KCCQ score has gone down by 5 points, there is 1.5 times. That means 50% extra risk of hospitalization and mortality in those where the KCCQ score goes down. We have all grown up using NYHA class in our daily practice. So even with the same NYHA class, the score matters. If you look at these pie charts, at every NYHA class, if the KCCQ score is better, prognosis is better. So it is important, it relates to mortality, it relates to hospitalization, and it is dynamic, it generally worsens with time, and we have to assess it repeatedly. And that is reflected in guidelines at point number 6. Assessment of quality of life should be periodically done as to see how your patient is progressing. Now coming to the treatment part, we all know, I'll not go into detail, that the first 3 cornerstones of therapy are RAS inhibition, beta blocker, and MR antagonist. We all know this. There is a 4th pillar also which has been talked about much, and we all agree on that. But coming back to RAS inhibition, we know that after paradigm heart failure trial, there is no doubt in anybody's mind that all patients of chronic HFrEF should be treated by ARNI and not by ACE inhibitor, because that trial showed that ARNI is much better. So ARNI may be considered as a first line therapy. Initiation of ARNI can be done de novo. That means patients should not be on ACE or ARB before you switch them to ARNI. And initiation of ARNI can be done after acute decompensated heart failure during hospitalization when patient is stable, euvolumic, and is not on inodilators. In chronic symptomatic patient, there is recommendation that those who are on ACE ARB should be shifted to ARNI as far as possible. Now, how does this therapy affect quality of life, which is the topic for discussion? There is not much proof that beta blockers improve quality of life, and there is a mixed result with ACE and ARBs that they improve quality of life. On the other hand, there is significant, quite robust evidence that ARNI improves quality of life. All these important parameters like domestic activities, sexual activities, KCCQ score, peak MBO2, 6-minute walk test, everything improves, has been shown to improve in randomized trial by ARNI. These are some common examples what is included in the score. Dressing, the ability to take shower by himself, climbing a flight of stairs, walking 100 yards, visiting family, jogging, doing yard work, doing his hobbies, household, etc., and sexual relationship. All these scores are significantly improved by ARNI as compared to ACE inhibitor. And this change in KCCQ or any score you follow occurs within first few weeks, say 8 to 12 weeks, and then it remains better for the rest of the time, say for 3, 4, 5 years. This score is definitely better with ARNI as compared to ACE. And if you look at the yellow chart, which is baseline, with on the left hand is ARNI, on the right hand is enalapril, there is a change of 8.7 points. And what we discussed, 5-point change is significant. While with enalapril, this is only 4.2 points increase. So that means significantly higher increase in KCCQ score with ARNI as compared to ACE. Similarly, the total score as well as the clinical score, if you compare with ACE inhibitor, this is significantly better in favor of ARNI. Now, this is a very interesting slide. If you look at patient's age and patient's KCCQ score, and if you look at the interception, the KCCQ score of a patient on ARNI at 70 years will be similar to what his at 60 with ACE inhibitor would be, at 60 with ARNI will be equivalent to 70 at ACE inhibitors. So that means the KCCQ score on ARNI will be at least 9-10 years better as compared to ACE inhibitor. It might sound, because we don't practice in Delhi, if you all remember when these newer anticoagulants came, there was CATS2 VASC score, and all of us thought it is too difficult to remember. But now we have all learned CATS2 VASC score, and we are calculating daily. Similarly, there is an app you can download, fill a few points, and ask your patient and calculate his short KCCQ 12-point score at each visit. And when you see his blood pressure pulse, you can see his KCCQ score also. And this is in brief the paradigm trial, which landmark trial, which showed 20% reduction in primary endpoint, 20% reduction in mortality, and 21% reduction in hospitalization with ARNI as compared to enalapril in chronic heart failure patients. It is also to be emphasized that this benefit of ARNI is in addition to beta blocker, is in addition to MRA, and if you look at the top, there is 62% reduction in risk of all-cause mortality with the ARNI as compared to counterpart. Similarly, 42% reduction in all-cause hospitalization with sacubitril valsartan, additional benefit. Does it lead to betterment in cardiac function? Yes. Although echo was not studied in paradigm heart failure trial, but subsequent analysis have shown there is a huge improvement. On an average, the ejection fraction is a double-digit improvement in ejection fraction with ARNI, say 12.8%. Similarly, end systolic volume and diastolic volume both are favorably affected. So dear colleagues, ARNI in patients with chronic HFrEF improves survival, reduces hospitalization, improves cardiac function as judged by ejection fraction and diastolic volume and systolic volume, and at the same time leads significant, consistent and robust improvement in quality of life, which is very, very important from patient's point of view. Thank you very much. On time, sir? What?
Nice lecture.
Oh.
So, you can give it to Dr. because yeah. So after this wonderful talk, and finally, the summary of this is that we have to think of quality of life, the improvement, and which drug improves it in heart failure. And that is very relevant to us when you talk of infections. That will worsen the quality of life. So the next speaker is Dr. Diman Kahali, and he'll talk of the strength of innovation in ensuring a better outcome. And after that, we'll talk about what worsens it and what doesn't worsen it. So I invite Dr. Diman Kahali to please take the floor. Please.
Does not come. Can you fix it? After this, thank you, Dr. Anil Motta, for asking me to talk on the occasion, and also the East Delhi Physicians Association. I was here a few years back also, so my time has been cut down. I was asked to talk about 20 minutes anyhow. What are innovative drug products? Because it's a very boring subject, I don't know whether you would like it or not. An innovative drug is the first drug developed containing the specific active ingredient to receive approval for use. Now, extensive research, rigorous testing across the patient profiles for clinical efficacy and safety before being granted marketing authorization. I was in different trials like EMPA Rage outcome trials, Synergy trial, then EMPA Reduce, EMPA Preserved and other trials, many other international trials, and I know personally how difficult it is to establish a molecule. And these are the US FDA criterion. One of the trials, that is with Idarusizumab, I was involved, and FDA sent 8 teams to monitor the parameters. So they are so much rigorous. And FDA new drug approval process is a very long one. The basic research, discovery, prototype, preclinicals, clinicals, FDA filling and clinical applications, IND and NDS, and this is very important during the development of drug. The development phase is a long one, and production and pre-commercial phase is also very important. I don't know how far you can see. These are the drug research and development process. Basic research takes about 2 to 3 years. Non-clinical studies about 3 to 5 years. Clinical studies 3 to 7 years. New drug application and review approximately 1 year. And then the drug is approved and ready for launching. And post-marketing surveillance and clinical studies, which are phase 4 studies, as all of us are involved in many studies. So these are the difficult in all 4, 5 stages and 6 stages this goes on. And this is a very long process. And this innovative drug product has its own shape, size, color, excipients, established efficacy, safety, scoring configuration, manufacturing process, it differs a lot, packaging, immediate or modified, expiration time, and sometimes label. Now, this is the short history of the anti-heart failure drugs. If you allow me, ladies and gentlemen, for 2-3 minutes, I'll finish it up. I remember in 1980s when first vasodilators came, hydralazine, nitrate, and AC inhibitors. I know the hue and cry when Eugene Braunwald has its first article on 31st of October, NEGM, in 1980, that the heart, after a heart attack, the left ventricle increases by approximately 1 ml. And if we give captopril 6.25 3 times a day, this enlargement of the heart can be prevented. So that was the first conception we had from none other than Eugene Braunwald. And then we know about the VF trial in American African patients who didn't tolerate these AC inhibitors or ARBs at that time. So at that time, ARBs were also not there. And consensus and SALT trial was there with enalapril. And in the 1990s, we saw a variety of trials and which opened our eyes. CBIS2 trial with bisoprolol 10 milligrams, not 2.5 or 5 milligrams. Sometimes often we can't give it full dose because of bradycardia or other reasons. And it showed that there was a huge 34% relative risk reduction of mortality by this bisoprolol. So that was eye-opening to all of us. Then came the MERIT-HF trial with metoprolol XL in a mean dose of 159 milligrams given daily, and that reduced the mortality by 32 to 34%. We also came across Copernicus trial because some people doubted that beta blockers cannot be given in severe heart failure patients, and so it was given in myocardial infarction patients or post-MI patients with NYHA4 class, which were very afraid of giving the beta blockers. So they initiated, after initial stabilization, with a minimal dose 3.125 BID of carvedilol, and that was the Copernicus trial, which showed a 25% relative risk reduction of mortality. Then came the RALS trial with spironolactone, and it showed a 34% relative risk reduction of mortality again. But as you know, spironolactone has some problems. It has got some anti-androgenic activity. There may be gynecomastia, impotency, and in ladies also you have very fewer symptoms. Male are mainly affected. So came the emphasis trial next post-MI patients with LV systolic dysfunction. This molecule, eplerenone, which was a next generation molecule to spironolactone. Spironolactone is more stronger. So when you start the therapy, you can start with spironolactone and you can go to this eplerenone. And both these trials showed a relative risk reduction, emphasis trial and the EPHISIS trial. And emphasis was with NYHA 2 to 4 classified patients, and EPHISIS was with immediate post-MI with severe LV systolic dysfunction patient. And both showed, EPHISIS of course showed 15% relative reduction. Then we came to this paradigm HF. I was in that ESC meeting in Barcelona, and they showed, John McMurray was presenting, and he showed that sacubitril valsartan combination reduced the relative risk of mortality by around 20%, cardiovascular mortality. That was the primary outcome, and the rate of hospitalization was also reduced by 20%, and the total mortality was also reduced. That was a secondary outcome of this paradigm HF trial, and John showed that it was reduced by 16%. So all these are called as foundation therapies, and to add to the list, as my previous speaker has rightly told, that to add to these 3 foundation therapies, the 4th one is SGL2 inhibitors, that is empagliflozin, dapagliflozin mainly in our country. We don't use canagliflozin that much. And DAPA-HF showed that there was a 20% relative risk, 17% relative risk reduction of cardiovascular mortality. That was the primary outcome, 20% risk reduction of hospitalization due to heart failure, and also there was a total mortality reduction by 16%. So havoc reductions in all the mortality figures. And this is a new molecule, vericiguat. I have used in a few cases in very severely, the indication of this vericiguat is that worsening heart failure. Worsening heart failure is defined which needs going to the emergency department or going to the hospital for admission, not necessarily admission, or the patient can go to his cardiologist to seek treatment when he has an episode of fresh heart failure. So this is the European Society guidelines for heart failure, worsening heart failure, and they are very Sigwart's indication. It's a class 2B indication for very Sigwart in that situation. Now you can see that there is some change in the guidelines, and 2016 ESC guidelines showed that angiotensin receptor neprilysin inhibitor has been given a class 1B status, and diuretics should be given. That's the first stage of treatment, though they don't reduce the mortality, so they didn't have been getting any place in foundation therapy. So foundation therapy are with beta blockers, with ARNIs, with SGLT2 inhibitors and MRAs, whatever it may be, spironolactone or eplerenone. Now there is a third one, finerenone, which can be given to CKD patients with little elevation of potassium. They are very good, and they have been shown to good in recent trials in heart failure patients also. It's very encouraging data coming on. Now coming to the other part of the Atlantic, the 2016 ACC-HA Heart Failure Society of America focused update on new pharmacotherapy for HA patients after the 2013 guidelines. They are telling in patients with chronic symptomatic HFrEF, newer classification 2 to 3, who tolerate an AC inhibitor, ARB replacement by ARNI recommended to further reduce morbidity and mortality. So we saw from all the data that ARNI has a huge place, and they have replaced in fact the AC inhibitors, which are the #1 for heart failure therapies, and they are not replaced by ARB. These ARBs are only given in intolerant patients to them. In between, some trials were there. I can't name with omilaprat. That was AC inhibitor plus neprilysin inhibitor, but that should be a negative trial because there was no significant reduction in mortality or morbidity, but that increased the incidence of angioedema by, it was 2.2% in the treated group as opposed to 0.6% in the placebo group. So it was off the field. Now this is the 2021 update to the 2017 ACC expert consensus decision on HF patient, answers to 10 pivotal issues about heart failure with reduced ejection fraction. Because of this totality of data, a direct to ARNI approach is now recommended. No AC inhibitor, the first one, or ARB. When de novo initiation of ARNI is performed, close follow-up and serial assessments, blood pressure, electrolytes and renal function should be considered, and any such usage should be considered concerns regarding the risk of angioedema or hypertension. Very little chances are there. And this is the Canadian Cardiology Society and Canadian Heart Failure Society recommendation, almost same. We recommend that an ARNI be used in place of an AC inhibitor or ARB in patients with HFrEF who remain symptomatic despite treatment with appropriate doses of GDMT to decrease CV death, hospitalization and symptoms, strong recommendation, high quality evidence they have told. They have not given 3C, etc. We recommend that patients admitted to hospital for acute decompensated heart failure and HFrEF should be switched to ARNI for an AC inhibitor or ARB when stabilized and before hospital discharge. There are at least 2 trials to support this data. We suggest that patients admitted to hospital with a new diagnosis of HFrEF should be treated with ARNI, a first-line therapy, as an alternative to either AC inhibitor or ARB. So largely, ladies and gentlemen, ARNI has replaced AC inhibitor or ARB, not because I am talking on by the sponsorship of Novartis in this great meeting, but because of the fact that ARNI is the cornerstone of GDMT for heart failure. GDMT is proven to reduce morbidity and mortality in HFrEF patients, and RAS, beta blocker, MRAs, SGLT2 inhibitors. Now we have vericiguat, it's an upcoming drug, and you see we treat the patient well with the diuretics, IV diuretics, furosemide, torsemide, and then we go back to all these molecules, and before discharge, in 90% plus patients, I can start all the 4 foundation therapies. So this is the unique complex of sacubitril valsartan. Actually, in the body, in physiology, in all of us, it is shown that the NAP, that is the neprilysin, there is an equilibrium between the breakdown and the formation, and there is an equilibrium between the vasodilatation, vasoconstriction and other physiological parameters. But in heart failure, the NP goes down. There is NP2, NP3, etc., and they go down, and as a result, there is heart failure intervening, and this has been found to be extremely effective molecule, and especially this salt which has been made by them. And the salt form is known to influence several physicochemical properties of the parent compound. These properties in turn influence the absorption, distribution, metabolism and excretion of the drug, and chemically stable, not hygroscopic, presents no processing problems and dissolves quickly from solid dosage forms. Depending on the mechanism of degradation, different salt forms impart different stability characteristics to the parent drug. Now, these are the factors affecting the salt selection process. I am seeing only a minute left. So, I have to finish. Impact of salt forms on absorption, stability, tolerability and safety. I can only tell that there is some difference between the innovator drug and the others one, the newer one. That is also evident with other molecules like ticagrelor. I won't name anybody, but a pioneer in the field of cardiology, he never used the other molecule, he only used the pioneer molecule. So, for ticagrelor is concerned, this is from their vast experience, expertise and knowledge. Now, this is the evaluation. They had 5 years of positive clinical experience when John presented the data, evaluated in 230 clinical trials, studied extensively in 3 lakh patients. 1,500 Indian patients fortunately participated. So, we have got some Indian data as well, and trusted worldwide with 78 lakh patient years of exposure, and the price is also less, which is very, very important for us Indians. So, ladies and gentlemen, to summarize, innovator ARNI has the strength of evidence across the heart failure continuum with extensive real world evidence across the globe. An innovator drug is backed by the strength of evidence following extensive research. Market approvals are obtained on safely, efficacy and quality of an innovator drug is well established. Thank you very, very much for your kind and patient hearing. Thank you, sir. Great. Thank you.
Okay, thank you. So we learned about the quality of life. We learned about the treatment of with the innovator ARNI as the first line therapy, and infections and heart failure being a malignant combination and having an interpersonal relationship. We want to talk to our specialist colleagues, and I must first thank both my speakers for giving a wonderful and on-time presentation. So first question is Dr. Anand Pandey. What cardiac and non-cardiac mimics of heart failure have to be kept in mind by us as intensivists?
Hello. I think, sir, background history, is very important to differentiate cardiac versus non-cardiac mimics, because the symptom is breathlessness, physical intolerance, inability to walk, dyspnea class 3, class 4. It's very tough to say it's cardiac or non-cardiac. So background illness like diabetic, multiple risk factors, diabetic, hypertensive, history of CAD, all this makes us to think about cardiac origin, other than maybe pulmonary or maybe another reason. So we have to rely on history. Examination is very important, like a simple ECG can tell us. A normal ECG virtually rules out heart failure. It's very clearly written. A normal, absolutely normal ECG, heart failure is unlikely. Then we can get POC, point of care testing, like NT-proBNP. A normal NT-proBNP, it has a very high negative predictive value. Normal NT-proBNP in a dyspnea, in emergency, is virtually we are not treating heart failure. And then of course an extra chest. I remember we had a patient had come with chest pain, dyspnea, failed to examine the juniors and diagnose an SCS. We got an X-ray chest and he had huge pneumothorax. So a clear history, examination, and then basic investigation of marker, ECG, and now echo is easily available. See, we are sitting at a place where tertiary care things are very easily available. Putting a probe and then looking at the LV function, I think one ECG and echo can virtually rule out PEH, RV dysfunction, LV dysfunction, valvular heart disease, pericarditis. A lot of things can be excluded. So I think non-cardiac and cardiac dyspnea. Second important is background history of heart disease. The patient has a background history of heart disease. Many times he may not have acute cardiac conditions, but they are very prone for respiratory infections. And that's why now adult vaccination, the vaccines for preventive influenza and I think pneumonia vaccines are class 2A indication to prevent recurrent heart failure. I think with this all backgrounds, we can easily, I think, exclude is it cardiac or it's not cardiac. Then markers are troponin I, troponin T, NT-proBNP, ECG, echo, serial evaluations of these. I think it's very easy to
So we have
evaluate.
to keep in mind the mimics, and we have to make the right diagnosis and not feel that that person is absolutely all right and rule out heart failure, because as Dr. Pandey said, that there are many reasons where you can have an apparently normal looking people or an alternative diagnosis. So heart failure is an important thing that we have to think of. Now again to Dr. Pandey, is a patient of known or pre-existing heart failure more prone to get infection? And do the markers of heart failure differ in their validity in a patient of infection?
Well, the same, I think, we extend the answer to the previous question. In patients of known or pre-existing heart disease, yes, they are. To large extent, higher the class of heart failure is, like those who are class 3 and class 4, if they have multiple comorbidities like diabetics, elderlies, they are very, very prone for, I think, respiratory infection. In fact, very common is acute worsening of heart failure during changing weather is very important. We see LV is same, heart functions are same, but they have consolidation on the both sides. Very important, which Dr. Dhiman has said, I mean, fourth pillar, SGLT2s. We had a patient who was on SGLT2, had come with an ACS, and I did his angioplasty. I did not change her SGLT2. Came back to me after, say, 4 weeks with a florid UTI, elderly female. So I think all these things, drug-induced or background disease, which makes them prone, we must keep a very high index of suspicion. Because problem is that there are certain markers. Markers are sometimes misleading also. So we have to think of clinical judgment is the best, and combination of markers and doing investigations is going to really solve the problems. There are a lot of conditions like sepsis can lead to rising markers. Anti-proBNPs are, they are all inflammatory markers actually. If you look at any marker, troponin T, I or anti-pro, they are all inflammatory markers. HSCRP is 100. Anti-proBNP is very high. But if patient has no active cardiac disease, I think we must look out for non-cardiac causes. And
so what you mean is that in presence of sepsis, the markers for heart failure can be fallacious. So that has to be kept in mind.
Yes, could be, yes.
Thank you. Now to Dr. Rajiv Pasi, we are asking a question that what are the gender-specific approach differences in heart failure and challenges in diagnosis and management, especially with vis-a-vis women, keeping in with the recent guidelines, and can pregnancy be allowed, and what considerations and care have you conveyed during pregnancy?
Thank you, Dr. Anil. By and large, heart failure in men and women is a similar process. There are some pertinent differences as far as women are concerned. The overall prognosis in women in heart failure is worse. But the good thing is that heart failure with preserved ejection fraction, the drugs which are available to us like ARNI and SGLT2 are doing better for patients, females who have heart failure with preserved ejection fraction. 2 large trials which were equivocal for men like the Emperor and the Paragon heart failure trial. For ARNI as well as for SGLT, they were clearly superior for women. So heart failure with preserved ejection fraction, the management is available for women, and women tend to do better. Overall, because of general negligence, general lack of care, and unfortunate family circumstances, women overall don't do as well as men as far as heart failure management is concerned. But basically the drugs are similar, the management, everything is same. But one very important aspect of heart failure in women is, can women undergo pregnancy, one, and what is the management if the patient becomes pregnant. First is that in patients of class 3, class 4 heart failure, pregnancy is a relative contraindication. It's not an absolute contraindication, but it's a relative contraindication because they generally tend to worsen with the fluid overload which accompanies pregnancy. Now, the biggest question is that a patient of heart failure who is on ACE, ARB, ARNI, beta blocker, MRAs, SGLT2, all of them have to be stopped. Once the patient becomes pregnant, all of them have to be stopped. The patient can be treated with diuretics, with beta blockers, and nitrates or hydralazine. So this is a limited armamentarium which is available to us once the patient becomes pregnant and there is heart failure. So ideally, heart failure, the patient pregnancy should be avoided.
Thank you. To Dr. Amitabh Yadanshi, I want to ask that what are the peculiarities of patient in the Indian population of heart failure as compared to the West, and do we have any India-specific guidelines?
Thank you, Dr. Anil. So basically there was a very elegant registry that was published in 22, the National Heart Failure Registry, which involved around 11,000 patients and 52 centers across 21 states of our country was there. So this is a very good database where we can answer your question. So the peculiarities that they noticed was that patients of heart failure, the average age was 10 years younger than our Western counterpart. The incidence of coronary artery disease was much higher. Almost 75% of patients had coronary artery disease. The incidence of males were much higher than females. That could be because of the fact that CAD was more common, or because of the fact, as Dr. Pasi mentioned, that sometimes because of the social and economic reasons, the females may not actually be approaching or getting treatment for heart failure, because all these patients were those who presented to these centers with symptoms of acute decompensated heart failure. So these were the basic differences, and then the usage of ARNI and heart failure devices was lesser in Indians as compared to the Western counterparts. Guideline directed medical therapy, almost 50% of patients received that, which is still poor to what is compared to the Western counterpart, but there was an improvement in this index because the earlier study showed that the GDMT was given at a much lower patient. So this is there. And then there are specific guidelines that are there. The CSIS paper that was published in 2018, which enumerates the treatment and the guidelines for heart failure patients. Then recently there was a paper on patients with maintained ejection fraction or heart failure with preserved ejection fraction. So as Dr. Pasi mentioned, SGLT2 inhibitors and ARNIs, especially in females, have some role in these set of patients. And then in worsening heart failure, again a consensus statement, just this year it was published in August, which again says that vericiguat is probably one drug that we can add in a patient who has had a recent worsening in heart failure. So there are Indian specific guidelines, but then again, they are not much different from the international.
Okay, thank you. So Dr. Chand Wadal, we want to come to the important topic that does infection cause heart failure, and do the biomarkers of sepsis change or get altered in patients with heart failure?
Yeah, very rightly asked, Dr. Anil. Thanks for getting me here. See, very often what is missed in heart failure patients is sepsis. Even if it is one of the commonest causes of patients getting readmitted more often without heart failure, when the sepsis is missed. So this is one of the very important areas that needs to be understood and excluded, as was rightly said. that you may have drug-induced or anything which is a complication, and you to ignore the UTI and the patient will come down to you with heart failure. The markers by and large are relatively stable, but they are not specific. So you may have high specific CRP, you may have PCT, but these are not very specific and high-end markers, but these are useful markers if you have a prognostic value, if you want to have some serial dilutions subsequently and try and repeat them, say procalcitonin or CRP as a marker, and besides that the cardiac markers, that is something else. But for the sepsis, those are the markers we can have. And then a very simple assay by now, which is in tertiary cares at least, is a blood culture. Whenever you have any patient having Kraft's, basal Kraft's, which you mostly think that is because of the heart failure primarily, but it could be because of the infection. So blood culture is one of the very good investigations which one can pick up right in the beginning. Once the patient comes with heart failure, at least you get a very broad 40% of the times the blood cultures are positive if you pick them up once they come to you without the antibiotic having pushed in. At that time, you may take a sample and then push in an antibiotic that you want to give for basal Kraft's. So that is how the sepsis gets missed. Sepsis having all immunomodulators that it sets in with all interleukins and the cytokine blast that happens in the body is huge, and it affects the myocardium in general. We may have sepsis-induced myocarditis itself, cardiomyopathy. If you miss and you only want to look at the other causes of heart failure, whether it's he has some valvular disease and other things, but if the sepsis is missed, the most of the outcomes come to a naught. So recognition of sepsis in heart failure is one of the very important areas.
Thank you. And one final question which all of you can take. What has COVID-19 taught us about heart failure? That is a question for all.
COVID-19, should I answer? COVID-19, we have seen lots of cases during the pandemic, and I think you have asked a very important question, because recently we know that the pandemic is out, but in our Bardhaman, 100 kilometers from Kolkata, 3 patients, elderly, 60 plus, all of them, and little other comorbid condition. They had, COVID, and all of them died. And during the COVID, we had the experience, because I worked from the day 1, 23rd of March, and we saw that it produces heart failure. It produces myocardial infarction with heart failure, with or without heart failure. And the difference between the COVID infection, MI, and non-COVID infection, we found that the arteries are full of thrombus. The thrombus load, I think Rajiv is also nodding in affirmity, and the thrombus load was much, much more in COVID patient than the non-COVID patient. And our good friend Sripal Bangalore from USA, within 3 months has come out a topic in NEGM. He had 46 patients, and he showed that the fixed blockage means which we treat, 70%, 60% blockages. The 50% of the patient or less than that, the blockages were less, and it was full of thrombus. But during the acute time, all of us have the problem during doing primaries, that whether this is, this is because of the thrombus alone or because of some fixed block. So we put some stents, thin strut stents, and they are highly, highly thrombogenic. And the propensity to develop atrial fibrillation is very high in post-COVID patient. They on the turn, if it's a very high rate atrial fibrillation, they produce heart failure. And sometimes they have presented with complete heart block, where temporary followed by permanent pacemaker had to be implanted. And we have seen that even after 15 days it persisted. So we kept for a few days and we implanted. And in various ways the heart failure has been precipitated, and there has been some direct myocarditis, and the Pfizer vaccine has been incriminated. You know about the recent medical legal suits in US against the Pfizer for precipitating heart failure due to myocarditis. In many patients, in papers they tell it the incidence is much higher, but authoritative data shows that it's not less than 5%, which I think is also a huge quantity. So COVID produces the myocarditis in various ways. Itself, infective, as my friend rightly told just now, and secondly, even by the vaccine effect, it is producing myocarditis, and the lesions are highly thrombogenic lesions, and they have it is a, better to tell it's a vascular virus than an infective virus, because we have not seen here. So when it started, our friends from, Hammersmith told that they found the arteries in the lungs are hugely affected, and it produces thrombosis and embolism. Similar thing in the cerebral stroke. Just if you allow, sir, 1 minute, I'm really fascinated to listen to the comments, and they have given so nice comments regarding heart failure in women. The ARNIs are very good for the women, and they have been found to be little better than men in women. And I totally agree to what you told, that in our society, all the societies globally, and therefore in all the major meetings in our seminars or conferences, we keep ladies' disease. We have in CSI a ladies' pink body that is solely by the ladies, because ladies are neglected to a large extent, both for diagnosis and for treatment, we cannot tell. And second important thing to our friends, many of you know about it, that ARNI, because you had a question, ARNI or AC inhibitor or ARB should not be given, in my opinion, to ladies of childbearing age. Because we don't know when they will become pregnant, because the effects of AC inhibitors, ARBs, ARNI are so severe, they cause calvarial degeneration, they cause agenesis of the nephrons in the kidneys. So in different ways they affect. So we should try to be away from this, which my friend has also touched.
So
Thank you very much.
I really thank you all for giving such a wonderful topic. And we had an interesting thing, because we are worried about infection and heart failure. So that's why you all were troubled. I thank you all for a wonderful time you have had, and I'm thankful to the audience for bearing with us. Thank you.
I request all the speakers and chairpersons to kindly proceed to the felicitation desk. I request Dr. Rajiv Bansal to felicitate the speakers and chairpersons. Now I request Dr. Ajay Kumar Gupta to come over to start the next session and the final one.
So this is the closing session of this day-long academic feast. And for the panels, we have Dr. Deepti Gujal. She is the Assistant Professor, Rama Medical College. Then we have Dr. Anvita Agarwal. She is the youngest member of EDPA. She's a DM infectious disease from AIMS, presently consultant at Sir Gangaram. Then we have Dr. Rajiv Agarwal. He's a consultant cardiologist from Meerut. Dr. Agarwal. And then we have Dr. Saurabh Srivastav. He's Professor of Medicine at JIMS, Greater Noida Institute of Medical Sciences. And today we'll be discussing something on the obesity and infections. So we all know that obesity is one of the hot topics nowadays, and now is the major focus of all the drugs in diabetes, and also there are major players in the obesity drugs also. So we'll be discussing that how obesity rules, or how obesity increases the infections, and what is the role of decreasing the obesity and hence decreasing the infections. To start with, my first question will be to Dr. Rajiv Agarwal. And Dr. Agarwal, we would like to learn from you that what exactly... Yes, you can come over here, sir. So whichever way you are comfortable, sir. You can present, sir. Sir ki slides laga do zara, lagi hai? So you can present, sir. So we would like to listen from you that what is the burden of obesity, and how does it affect on the type 2 diabetes and the heart failure or the CV risks. Pointer. forgot to introduce the chairpersons. Dr. Amit Sharma, he is Professor of Medicine at Lady Hardinge Medical College, so he'll be chairing the session.
Thank you. I think you had been listening to a lot of infections since morning, and I will not be talking much of infection and obesity, but I'll definitely talking inflammation, obesity, diabetes, and how we look at it. And diabetes and obesity, they are twin partners. Whatever you see today has to be looked into the perspective that what is going to happen tomorrow. Each time you see a diabetic patient who is obese, we say, look for a Yantel syndrome. I have made it fascinating because you must carry it home. Yantel was a girl, Jewish girl in Poland, who was disguised like a boy because Jewish tradition does not allow females to be religious teacher. So she was a student of her own father who was a religious teacher. And it came out very late that she is his girl and getting a religious preaching. This is one of the best Polish movies. You can Google it, Yantel. And the idea of talking Yantel syndrome is diabetes is look for obesity and cardiovascular disease. Don't forget, when you treat diabetes, don't forget diabetes and obesity. There is a triad between weight, diabetes, and CVD. And as the obesity increases, each biomarker increases disproportionately, whether it is hypertension, dyslipidemia, or combination of two. So there is a term which we use, diabesity. Obesity associated with diabetes is called diabesity, and it's a unique syndrome because in this syndrome, you have to take care of diabetes, you have to take care of vascular compartment, and you have to take special care of obesity. As the obesity increases, CV event increases, they are directly related to BMI. Atrial fibrillation is one thing which you should remember, that it correlates directly with a BMI. So if you happen to see a patient of atrial fibrillation who is overweight, one of the simplest strategy is to reduce weight and physical activity. This had been a conventional model of looking after secondary prevention from cholesterol to inflammation to thrombotic risk to triglyceride, LP, and diabetes. What is missing in this is focus on weight, because when you do a focus on weight, it holistically reduces every compartment when you look it in isolation. I think that is where we want to talk. There is a concept of adiposity. There is a concept of adiposopathy. So fat becomes a disease. There is a concept of obese but normal biochemistry. That means there is a person who is overweight, but his blood sugar is fine, his TG is fine, his HbA1c is fine. So he'll say the mechanistic pathways are taken care of. Then when adiposity becomes adiposopathy, that is our interest, then it is infiltrated, infested by several cells which produce neurohumoral substances, and macrophages are the most important. So that is one transition, and these cells become insulin resistant. They are resistant to lipolysis. And the simple person may become diabetic. Simple person, like in adiposopathy, will become a very high CV risk. Clinically, you just know by measuring CRP that this patient has turned from adiposity to adiposopathy. When adiposopathy happens, there is ectopic fat in relation to ventricles, and this is adipose tissue, ectopic adipose tissue. And those who follow cardiology, is very common risk factor for acute coronary events, very common for atrial fibrillation, very common for HFpEF. Many of you who do echocardiography, you find an echo-free space. There is no fluid. It is actually ectopic adipose tissue. And diabetics are more prone for it. And it is a very, very high risk feature. Now we have specialized CT scan imaging. We call it fat attenuation index. When you do coronary CT, you can ask your CT person to calculate FAI. And if the FAI is high, these patients are prone for acute coronary event. So fat around the heart is a very, very bad thing, far worse than fat across the abdomen. So obesity is the central stage. When you reduce BMI, everything goes down, and there is, when you reduce weight, then there is reduction in hypertension, triglyceride, NFLD, T2DM, everything goes in your favor. So weight reduction is a very, very important thing. It improves blood pressure, triglyceride, LDL, and if you lose 5% of body weight, you reduce 50% hazard of CVD over a 10 years of time. It's a huge gain, huge gain. So 5% weight reduction is translating into 50% CV risk reduction. And the problem is there are very few drugs which reduce weight, largely anti-diabetic drugs, they increase weight. SGLT2 inhibitors, they do decrease weight, but the best drug to reduce weight is GLP-1 receptor analog. And one of the mechanisms is that liraglutide, which is GLP-1 receptor analog, is a small molecule, crosses the brain, and it decreases it inhibits your satiety, it improves satiety and decreases your hunger energy. So it is a central mechanism of reduction of appetite. Many of us believe that obesity is a behavioral disease. No, it's a neurobiochemical disease. The metabolism is changed, and obesity is not simple a behavioral disease. And when we use GLP-1 receptor analog, it reduces weight and it is anti-atherosclerotic. And it produces large number of metabolic effects. The prototype drug is semaglutide. In India, we don't have the injectable semaglutide, which is once a week. What we have, a tablet of semaglutide, which is oral with the name of Rybelsus. It comes in 3 milligram, 7 milligram, and 14 milligram dosage, which is being used for this purpose. And it reduces inflammation, oxidative stress, and collagen content. What is good thing to understand those who do medicine, that SGLT2 inhibitor do not reduce stroke. So there is a directional discordance between the two vascular bed. Two vascular bed means the coronary vascular bed and the neurovascular bed. Strokes are increased, MIs are decreased. While GLP-1 receptor analog, there is directional concordance. Everything is reduced. So if you have to have a patient of diabetes with stroke, GLP-1 receptor analog, they are the drug of choice. Just to summarize everything, Sustain 6 is semaglutide subcutaneous, it is oral. We don't have an outcome data of oral. When you combine these two trials, there is 24% relative risk reduction. So just summarizing that semaglutide increases the CVD-free life years. And it is a drug which works on all the compartment from weight reduction to decreasing inflammation, and it has got a powerful anti-atherosclerotic effects. It is also shown to have renoprotective effect. So if we summarize, then GLP-1 receptor analogs are ideal drugs for diabesity because they take care of diabetes, they take care of your weight, they take care of your cardiovascular disease, what I told you, a Yentl syndrome. So I'll end up by just showing this slide. half protection is not a protection. Half helmet is not good enough. So if you are focused just on glycemic control, you are not doing good to your patient. You have to have a full helmet, vascular compartment, as well as obesity management. And I think in the shortest possible time, what I can communicate, GLP-1 receptor analog, they are ideal drug for this purpose, and give your patient whole or the full helmet. Thank you very much.
Thank you, Dr. Agarwal. And like Dr. Agarwal has very well mentioned that there is a strong need of decreasing the obesity to control the diabetes and the infections also. Like I was hearing from the previous speaker that though we have gone out of the pandemic, but still we have some spurts of COVID-19, and we had seen this COVID-19 2 years back, and we had the experience that the obesity means the patients who were obese, they had a bad outcome during this COVID. And today also means we are having many LRTI patients and many patients in the ICU who are obese. So Dr. Saurabh, my first question means the second question will be for you, that how do you see this obesity in the infections in the ICU, and like LRTI we are treating, or you were a very pioneer person in the Greater Noida part for this COVID also. So what is your experience regarding ICU, COVID, obesity?
Thank you, Dr. Ajay. And the thing is that I have seen COVID patients also, and if we see that in obese patients, the risk of LRTI increases. So whether it is influenza or it is COVID, there are many studies which have shown that the risk of influenza infection, and along with that, the mortality as well as morbidity increases in obese patients. In COVID, we have seen that the patients who were obese, they were more prone for complications, they were more prone for prolonged hospital stay, they were more prone for mortality also. The respiratory functions are basically compromised in obese patients, and we have seen that there's a expiratory flow limitations in obese patients because of the obesity. The lung volume is compromised, and there is a component of basal atelectasis and the ventilation perfusion mismatch also. So all these things, they contribute to the poorer outcome and the increased risk of infections and the poor outcome of the infections also. And also we have seen that, as Dr. Rajiv has shown, that there's an increased risk of comorbidities along with diabetes, along with the obesity. We have n number of infections along with that. We have diabetes, we have hypertension, we have coronary artery disease, we have CKD. So all these comorbidities also increase the treatment aspect also, and the length of the stay in the hospital also. Again, the obese patients have a risk of ventricular thromboembolism. The patients are in prolonged bed rest, the movement is less, so their stay increases, and because of the prolonged stay in the bed, the chances of thromboembolism increases. And again, one of the slides which Dr. Rajiv was showing, that the adipose tissue is there, and this adipose tissue ultimately, when there are numerous cytokines along with that, and it becomes a chronic inflammatory state. And this chronic inflammatory state again is insulin resistant, and all these things make the person prone for infections, and these things are very much important when we are thinking the patient and seeing the patient in the ICU point of view. And in ICU, the length of the stay prolongs, there's a difficult intubation, there's more chances of infections being cured in a later part. There are the problem with the drugs also, I think these parts will be taken care of. Drugs, there are pharmacokinetics changes, all these things are there. So the obesity, if a person is obese, the say is that if a person is obese, then there are fair chances that the morbidity will be more, there are fair chances of mortality, and if it is not being taken care of properly, then the length of hospital stay will be more.
So in all means, what I understood is that in toto, obesity will increase the morbidity, prolong the stay, and there are more chances of getting complications.
Yes.
So, like you had mentioned about the pharmacokinetics and pharmacodynamics. So, Dr. Anvita, I would like, as an infection specialist, so how does this pharmacokinetic, pharmacodynamics, and do we have any drug dosing change in obese people? So, I would like to hear it from you because, like, we have a particular dosing schedule. Okay, but that is okay for a person of 60 or 70 kgs of weight. But if the patient is around 100 kgs, 110 kgs, so will the same drug work, or is there a difference in the dosing schedule, the infusion schedule? So any takes on these?
Thank you so much, sir, for the question. So, as we've already understood that obesity comes with a whole baggage of multiple comorbidities. So, it's a challenge as such to save a patient, but it also brings a lot of therapeutic failures and difficult to treat infections. So, first of all, the resistant infections and the strains of recurrent infections makes it difficult to treat. Secondly, the PK/PD parameters or the drug distribution actually reaching the organs is very difficult. So if we look at surgical prophylaxis, what are we essentially wanting is that before we plan a surgery, our antibiotics should reach the skin so that we are achieving proper good surgical prophylaxis. But in an obese patient, the adipose tissue is much more than estimated, much more than what a drug can actually reach in that particular amount of time. Hence, this whole strategy of a dose before a surgery actually can fail. So in surgical prophylaxis and in treating various LRTIs, in treating various UTIs, in treating sepsis, we have to be very, very cognizant about what drug we are choosing and are we giving the right dose, are we giving it in the right way. So if we discuss a few drugs which we commonly use in the ICU and if we commonly use in our day-to-day clinical practice. So we understand there are two types of drugs, concentration-dependent drugs and time-dependent drugs. So the drugs which are time-dependent killing, such as are beta-lactams, for example, carbapenems, are cephalosporins, are Astrana, all these drugs basically are going to be requiring higher dosage and prolonged infusions so that a therapeutic level is properly attained. So what we have to make sure is that if we are giving, if the maximum limit is thrice daily dosing, for an obese patient, we can make it 4 times in a day. And during those 4 hours, rather than giving a bulk push of the dose, we have to give it for over 3 to 4 hours. So while the patient is on bed, ensure that there's a continuous infusion of antibiotics so that throughout the 24 hours, at least 20 hours, the time of the drug is achieved in the blood levels and the concentration is properly achieved. Then if we look at aminoglycosides and even vancomycin for that matter, so these are basically these are the drugs which are concentration dependent killing. So here we have to be aware that the volume of distribution is not that affected. So the drug clearance by the kidney is what is affected. Here the patient can actually land up into toxicities. So if we exceed the dose, that is the maximum limit, like our natural thinking is going to be obese patient है 100 kilo का है 100 mg per kg के हिसाब से we increase the dosing level. But we can actually cross the toxic levels and we can actually end up into renal failures much sooner than the usual patients. So we have to be very careful before increasing the limit of the maximum dosing. So here the concept of therapeutic drug monitoring comes into play. So we all are tertiary care centers where we can do vancomycin drug levels. So it's very, very important that for an obese patient where we're not sure about whether the drug levels are being achieved or not, we do a therapeutic drug monitoring, that is trough levels. Just before giving the next dose, we get a serum sample, we test it for vancomycin drug levels and we see that are we actually achieving therapeutic range or we are crossing it. Then coming to the most favorite antibiotic, this will be the last, sorry, polymyxin and colistin. So these have very challenging drug toxicities. Colistin can cause nephrotoxicity very, very easily. So normal dosing regime or the weight-based regime is not what is indicated. Here we have to go for the ideal body weight or the adjusted body weight dosing, and we have to be very careful about the capping of the dose. We cannot be crossing it more than 300 milligram per day. We cannot be crossing the nephrotoxic range of the drug, and we should be ideally using a combination. Polymyxin alone causes high rates of therapeutic failure because of a narrow therapeutic index. So multiple antibiotics have a lot of caveats, they have a lot of challenges in a obese patient, and because of changing critical augmented clearance or the renal clearance, we have to be very careful while we are administering these drugs. Thank you,
Thank
sir.
you, Anvita. And just like you were mentioning some examples, like what about means most of the physicians in the ICUs, we use just say Targocid or we use Tizact. So any example of these two drugs which you can?
So, sir, unfortunately, Ticoplanin or Targocid, this drug is not FDA approved in India. Sorry, it's being used in India, but it's not FDA approved. So its dosing is very, very limited to the general population. So hence, in obese patients where the PKPD parameters are haywire and the patient is critically ill, it's better to choose drugs which have very good studies in the background. So for example, if you want to choose a gram-positive drug, I would prefer going for linezolid rather than Targocid, where I'm sure that a 400 mg/OD dosing for a lean thin patient cannot be equivalent to that in an obese 150 kg patient. So choosing drugs where we have good databases is very important in such patients because therapeutic failures are very, very common.
Thank you, Anvita. And like we all have been facing in our OPDs, like majority of the obese patients, they have some skin infections, some skill fold infections, and like we have the post-op patients who have those delayed wound healings and all. So Dr. Deepti, what is your take on obese patients for these things? What is your experience for a obese patient for a skin infection or skin fold infection and delayed wound healing infections and all?
Thank you, Dr. Gupta. So there are many factors which lead to increase in the skin and soft tissue infections in obese patients. Obese patients, they have increased surface area, there is increase in the sweating, increase in the sebum production, and there is loss of integrity. The skin barrier integrity is lost because of the increased adipose tissue. And obesity, as sir said previously also, it's a pro-inflammatory state. So a lot of things happening over there with increase in the cytokine production, and there is a change in the microbiome of the skin. So all these factors contribute to a lot of skin infections. Like fungal infections are there and more in obese people. Obese people tend to sweat more because of increase in the sweat and the sebum production. So in intertrigos are seen mostly in obese people, and diabetes is associated with the obesity. So a lot of infections, lot of skin and soft tissue infections are seen in obesity, obese people. As regarding the delayed wound healing, there are a lot of factors behind the delayed wound healing, which is seen mostly in post-surgical cases, because delayed wound you have to understand the wound healing is basically four things. There is a clot formation, there is inflammation, then there is a clearance of, and then there is a remodeling. So collagen is not produced properly by the fibroblast. So the wound which is in obese people is basically a hypoxic wound, because the adipose tissue the adipocytes have grown in the size, but the vasculature is not enough. So there is a relative hypoxia in such wounds, which leads to delayed in the wound healing. The angiogenesis is decreased, is delayed, because anti-angiogenic factors are produced by your adipocytes, or angiogenic factors are not produced enough in the adipocytes. Obese people tend to be micro and macronutrient deficient. So all these factors contribute to your skin and soft tissue infections and fungal infections, and there's delayed wound healing seen in cases of obese people.
Thank you, Dr. Deepti. And like what we understand is like the infections, they are more common in obese patients. So just before I hand over the mic to our chairperson for summarizing, just a crisp one-liner from each of our panelists. Like I'll start with Dr. Agrawal. The treatment of obesity, sir?
Treatment of obesity is awareness of obesity. Once you are aware, things are easy. And obesity, it will have mechanical as well as neurohumoral effects. So I'll say as a cardiologist, I am not an obesity expert. We try to manipulate drugs which we use, which can reduce weight. So I am not an obesity person, but I'll say look after your diet, keep walking. Even insomnia is associated with the obesity. If you sleep less. So if you ask me whatever I have learned in cardiology today, I'll say train your mind to sleep like a child the way you used to sleep when you were a young boy and your mother used to wake up, you are getting late for school. If you have done this, you are going to live 80 years. Nothing will happen. The problem today is sleep, sleep, sleep. What will? 8 hours sleep. If you work 16 hours a day, you can buy Taj Mahal. If you work 16 hours a day, you can buy Taj Mahal. वो तो permanent सोना है. So you see, I'll tell you one story because I'm biologically elder to you all guys. There is a doctor, a friend of mine. I'm older to him, don't worry. He must be at least 6-7 batches junior to me. There was a doctor friend of mine from Modi Nagar, and he was MD medicine. And he came to show me for a coronary problem, and I was at the end of the day free. एंड मैंने उनको कहा कि डॉक्टर साहब कुछ बताइए जीवन में क्या सीखा है. तो पहले बोले आपको क्या बताऊंगा. फिर आई इंसिस्टेड, मैंने कहा गॉसिप टाइम, टेल समथिंग. सो ही सेड वी वर 3 friends, one MS ophthalmics, one orthopedics and MD medicine, and I was the best among the 3 in my assessment. And I miserably failed in my life. My practice was nothing. And those 2 guys, they were earning like hell. So बोले डॉक्टर साहब ऑर्थोपेडिक वाला मर गया, मरे हुए 10 साल हो गए हैं, और जो आई वाला था उसको CVA हो गया. मैं अब भी चल रहा हूँ और मुझे लगता है मैंने उनसे ज़्यादा कमा लिया है. So what is important in life is how long you practice. Whether you finish your inning at 85, finish at 70, at 65, at 50 with CVA, that makes a difference. And once again, I'll take a liberty. I am a 100% hardcore practitioner. If you go to my area, they will tell you I am swarmed by patients. GB पंथ का मैं प्रोड्यूस हूँ और मैं किसी भी सरकारी अस्पताल से ज़्यादा जल्दी मरीज देखता हूँ. On an average, I see 23 to 25 patients in an hour. Each patient is paid. What is important is how much you are committed to the patient, and your health should permit you to practice for a very long. And each year you get older, not only you get wiser, you get wealthier. When I came to Meerut from GB Panth Hospital in 92, I was the only DM in whole of the central and western UP. At least 35 district, I was the only district DM cardiology, and I used to get patient from Tiri Garhwal. Today there are 15 cardiologists in Meerut, and I don't have time to breathe and piss. I work so much. So each year you go, you get incremental practice. So wait for your turn when you are older. You dictate your terms, you dictate your price, and the biggest asset you have is your honesty and experience, which a younger person cannot have without investing time. So try to do practice at 85 rather than chasing money at 60. Because if you do 60 to 85, you can definitely buy Taj Mahal.
What I could learn from sir is that obesity and infections, both are the hindrance to his practice. So he has avoided both of them, and that's why he's
I always say, I always say, कम्युनिटी इतनी बड़ी है, आप जो चाहे वो कर लो. एक नेचुरल इलनेस का लोड है, लोगों को टाइफाइड भी होगा, CVA भी होगा. डोंट. Yes, Lalit is my class fellow.
Sir, there has been some magic potion which you must have taken in your batch. मुझे लगता है सर आपके बैच में कुछ आपने जादू की चीज पी होगी. आप मतलब everybody is so young and energetic at this age. Sir?
It is not the platform to tell you. And you see, and you have to have a control on your mind. If you don't have control on your mind, you can't practice. And each year, you will be wealthier than what you were. Each year. And I'll tell you, I have never stood second in my class. I am always a university topper, Delhi University topper, always. And आज भी मेरे से ज़्यादा कोई एकेडमिक लेक्चर देने वाला नहीं है यूपी में, टीचिंग हॉस्पिटल्स की बता रहा हूँ मैं. आई डिड सानी के साथ, इनका जो चेयरमैन है गंगाराम का, उसके साथ लेक्चर किया, सुबह डॉक्टर के सेठी का लेक्चर किया, अब यहाँ आ रहा हूँ. सो you have to empower yourself, you have to enrich yourself and maintain a cool. Lalit is my batchmate and he will say, मैं यहाँ होता था, मेरे पीछे वाला लड़का 10 मीटर, मेरे बारे में एक आ जाता था, पहले से 10 तक राजीव अग्रवाल है.
सर एक बार ताली हो जाए सर इस बार.
This is just to tell you that organize yourself. This is not to empower myself. Just organize yourself. We are very, very important people for our family. हमारा अभी एक न्यूरो फिजिशियन कोलीग था, आज मैं आपके इस चक्कर में उसमें नहीं जा पाया. What I am trying to tell you, we are one-man army. If I am not there, my family is nowhere. If I am there, my family is the front-line sitter. हमारा कोलीग था भूपेन चौधरी, उसको हाइपरट्रॉफिक कार्डियोमायोपैथी थी, DM न्यूरोलॉजी. He expired last week. And what happened? Amidron toxicity, irreversible liver failure. So, you must understand, आपके बिना आपकी family बिल्कुल zero है. So, look after your health. आपकी family को कोई पूछ,
Thank you everybody. It was a, sir.
You see, you have to organize it. Each patient pays me 1,000 rupees. So they don't come as a government hospital. I am surrounded by 5 people. My sister writes the whole history on the patient's side. There is a boy, sister, who writes the vitals of the day. And the moment patient comes to me, I am on the prescription. If anybody have you seen, I write the minimum number of drugs in the whole northern India. If you ask me, Rajesh Rajput, Parsi, ये सब मेरे juniors हैं कि डॉक्टर राजीव के पर्चे पे 1 या 2 दवा लिखी होगी. And that gives me compliance. मेरे को अपने बारे में ये मुखालता है कि अगर मेरा पेशेंट गुप्ता जी के पास चला गया तो he cannot retain it for more than a month. Why he will not be able to retain it? Because all of us are obsessed to write many drugs. All of us are obsessed to write investigation. All of us are obsessed to call them every second week. So my patient can't go anywhere. They just can't, because I am the cheapest, most experienced, most sought of doctor. So you have to make yourself indispensable to your patients.
Right, sir. Thank you.
Thank you, sir. I would like to just conclude this session. We have a lot about the diabetes, obesity, because it leads to all the complications. One thing is that the duration of diabetes is directly related with the mortality. There are few limitations we need to look up in the near future. What are those? We don't have the very strict guidelines regarding the dosing in the obesity patients. And second thing is that we don't have many antibiotics. We don't have any other antibiotic after 1980s. So we are supposed to use these antibiotics judiciously, whichever are there. That is all about this topic. Thank you.
Request Dr. Lalit to go ahead with the felicitations. I request Dr. Makkar to give closing remarks.
So I think that
with that last panel discussion, we come to the close of the day, and I will take this opportunity to thank each member of the EDPA and the organizing committee for a very successful conference, and I believe we will take back some key practice messages. I think it has been a good conference in the sense that we were able to get some pearls of wisdom that we can go back and use in our practice. So with that, thank you very much for staying back till the end of the conference. And I would like to personally thank a few members. Of course, the master of ceremony today has been Dr. Swati, relentlessly, working since the morning, very early in the morning. So a big round of applause to Dr. Swati. And of course, Dr. Paras Gangwal, our president of the EDPA. I don't know, he's busy somewhere, but thanks to Dr. Paras. Thank you, Dr. Paras. Dr. Rajiv Bansal, thank you so much for being the chairman for the scientific committee. Our organizing co-chair, Dr. Harshita Tyagi. Thank you, Dr. Harshita. You've been a great pillar of support. And of course, our two organizing secretaries, Dr. Sumer Sharma and Dr. Bikramaditya Deb. It's just not possible to do a successful conference without the hard work and the legwork, which all these members have been doing. Thank you, Dr. Ashok. Dr. Vijay Arora, sir, thank you for being there. Dr. Viresh, our finance support person, sir, thank you very much. And finally, of course, Shambhu, he's been Shambhu, thank you for being our EDPA manager and coordinating all the activities. And thank you to all the audience once again. Thank you. Thank you. Have a good night. Thank you.